Okay. Welcome to today's meeting of the Health and Social Care Select Committee at the London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. The purpose of this committee is to monitor services provided by health partners in adult social care and review their performance. We also undertake in-depth reviews and witness sessions on specific topics and submit our findings to the decision-making cabinet. My name is Councillor Nick Denys and I'm chairman of this committee. Before we start, I have some important housekeeping for everyone present. Please ensure your mobile phones are on silent. We're not expecting a fire drill, so if a fire alarm does go off, please follow Nikki out of the building. Please keep your microphone muted when you aren't speaking, then unmute to speak. And as chairman, I will call on those to speak. Okay, fantastic. So we're ready to move on to the agenda. Nikki, do we have any apologies for absence?
Chairman, we've had apologies from Councillor Alan Chapman.
Thank you very much. Declarations of interest? Oh, no declarations of interest? No, fantastic. We have the minutes from the 21st of March. Are we happy with those minutes, or are there any comments on those minutes? Are we all happy? Fantastic. So those are passed. Excellent. So number 4, exclusion of press and public. Everything is going to be public. Fantastic. So we go on to our only and main, but very packed items. So my ambition is for us to do this all in 2 hours, but we shall see. My ambition, I'm an optimist, and usually my ambitions never quite meet it, but anyway. Okay, so we have one of our biannual really important sessions where we have our main health partners in the borough come and speak to us about what they've been up to, what challenges they face, what they've done really well as well, because we want to celebrate good performance too, and what they're thinking about over the next near-term future. So what we're going to do is Nikki sent around a list of who's going to speak in what order. After each person speaks, we'll have a chance to ask questions. Obviously, with health, everything's interlinked. I think the health service is almost like the body, isn't it? Everything's interlinked. But everything's interlinked, so obviously, Keith is going first. If he talks about some stuff which you personally are interested in, so for example, Lisa and Chris, you're going at the end. But if there's stuff that comes up and you think, yeah, this is to do with us, please put your hand up and come in. And also, if you do that, feel free to make your presentation shorter at the end if you feel like it's necessary. But don't if you don't feel like it's necessary. So even though there is an order, I want it to be a true discussion of what's going on, because even though there is an order, health isn't compartmentalised really, because you're all working together and all that sort of stuff. So does that make sense? Excellent. Okay. So we are ready to start. Philip, Philip, you wanted to say something before we started?
Well, yes. An observation really, more than a question. I'm not sure who I'd direct the question to, but I have raised on a previous occasion the importance of us having the full suite of current performance indicators to help inform the discussions we're having, and I trust that we have that, and hopefully that the presenters can address that in their comments to us, because we can't overstate the importance of the importance of this session. It really is an important responsibility for us as members. So I just make that point, if I may, at the beginning. Thank you.
I think my reaction to that is that maybe we as a committee, maybe over email, maybe at our next meeting, I think we need to think about what sort of information we would really appreciate, because obviously there's so much information, there's so much work that's done. So maybe if we could think about what sort of information we should ask for, then in the future we can maybe direct that towards our health partners to sort of get them to answer those questions. Philip?
If I may, yes. I mean, look, if the Department of Health and Social Care guidelines isn't explicit about that, if it's not an exact science and a judgment that we have to make, then yes, I'm up for doing it that way. I'm guessing that it isn't, judging by that response, but that's fine. Happy to proceed in that manner.
Great, excellent. Okay. Right, so we're ready to start. Keith, from the Hillingdon Health and Care Partners, you're first.
Councillors, good evening, and thank you for inviting us. I'm going to take the presentation as read. I'm not going to take you through page by page. I'm just going to do a voiceover to the presentation in association with my colleague Sue Jefferson from the North West London ICB. So the paper that you got in front of you, and just to pick up Councillor Cawthorne's point, is backed by some place-based indicators that we've included, and they are North West London indicators, so we can be assessed against other boroughs. So what you've got in front of you is how health and care organisations in Hillingdon have worked together as a place-based partnership to deliver our health and wellbeing strategy for 22-23. Now, the focus of our work in the last year has been on four main things. Firstly, about embedding population health management and addressing inequality in Hillingdon. Secondly, to ensure the best use of resources to address the financial challenges that health in Hillingdon actually faces. Thirdly, about developing and progressing the clinical models and activity shifts for the new hospital development, which Council, we have discussed at this meeting on a number of occasions. And then finally, delivering the three main priorities of our place-based transformation programme, which are on developing integrated neighbourhoods, improving whole population health and well-being, about reactive care, tackling unwarranted emergency department attendance, and then end-of-life care, which is around joining up and integrating care for people at the end of their life. Now, to do this piece of work and to progress those objectives with partners, we've undertaken a wide-ranging review of how we currently deliver health services in Hillingdon in order to define what we call a future state operating model, with the goal of actually delivering more care close to home for people. The outcome of that review is set out in Appendix 1, and I do believe we discussed this at our previous meeting. What I'm going to do now is just invite my colleague Sue just to talk to and reference particularly the place-based indicators that are in the pack, with a focus on where we've done well and where we need to do more and where we need to do more work. So, Sue, if I could hand over to you.
Thank you, Keith, and thank you, councillors. Taking you through some of the place-based key performance indicators that Keith has suggested derive from North West London, and in your pack you've got how Hillingdon is progressing against the other boroughs across North West London ICB. Some kind of key achievements that we really want to highlight for you tonight, and I've got some more detail in terms of answering questions should councillors ask questions, but some key headlines are: in 22-23 in Hillingdon we delivered 6.4% more GP appointments than in 21-22, including 17% more face-to-face appointments. This equates to something in the order of 620,000 appointments across the year. We are one of the highest performance in North West London ICB for the uptake of vaccinations, and I've got some of the detail behind that. We have the lowest admission rate for people who are over 65 years or over with severe frailty in North West London. We have the best performance across London for the proportion of hospital discharges by 5 p.m. each day, and I'm sure colleagues in THH can talk a bit more about that. And we also have overall the lowest overall average length of stay for patients needing to stay longer than a week. 70% of people with a serious mental illness who are registered with our GP practices received a physical health check against the national and the North West London target of 60% in the year 22-23, and 81% of people over 14 who live with a learning disability have had their annual, and are registered with GP in Hillingdon, have had their annual physical health check against a national and a North West London target of 50%. So some of those figures that I've quoted to you just now are March data. In your pack I've given you the February data, but I've just had a bit of an update on some of them for March. So the LD one, for instance, is an update for March. There are areas for improvement. We need to continue to reduce unwarranted ED attendances. There's more work to be done around hospital discharge, and I'm sure we will come back to that. We do need to improve our uptake of bowel cancer screening and dementia diagnosis. I have a little bit more detail on that if you need to, and improvements in hypertension, blood pressure case finding across the borough, particularly under our population health management programme to address inequalities across the borough.
I think that was 6 minutes, Councillor.
Fantastic. Okay, So we now move on to questions. Rita, before the meeting started, you sort of mentioned to me that you wanted to really ask about the impact of GP appointments.
Yes.
So as GP appointments were mentioned in the presentation, do you want to ask your question or make your point?
Yes, thank you, Chair. Yes, so we mentioned it with a 6.4% more GP appointments. I'm struggling with that figure from personal experience as well. Trying to get a GP appointment is a nightmare. And prime example today was I waited 13 minutes at 8 o'clock to be told there's no appointments, and I couldn't get onto patches. And you can't get into patches because there aren't any appointments available. So I'm struggling on how, and I'm sure viewers on YouTube probably have got far more worse experiences than I have. So how are we actually moving forward with the availability of GP appointments for patients? Because I think there's another part in here that we talk about accident emergency, 71,000, when we look to see how many we've seen. How many of those appointments could also have been seen by a GP and not by accident emergency? Because people, natural instinct would be, I can't get a GP appointment, so I'll go to A&E when I know I will be seen.
So yes, I mean the reality is there were more GP appointments in 2022, so it was 690,000 appointments across the year, compared to 587,000 the previous year, which is an increase of 17.4%. I mean, it's a significant increase, and a decrease of those appointments being done virtually. But we absolutely know that within that, demand has continued to rise and will continue to rise, and the capacity to meet that is not rising. So the numbers of doctors, nurses and GP receptionist staff is not rising at the rate that the request for appointments is coming in. Hence, long waiting lists and our 8 a.m. Monday logjam of telephone calls, which absolutely happens. There is work happening right now on the digital side to try and improve through cloud telephony, where NHS across North West London, including Hillingdon, we're working with NHS Digital to improve our cloud telephony facilities, so to allow to stop the Monday morning logjam of phone calls and people just hanging on to be told at the end, as you have exactly experienced. So that is what we are doing, because we recognise that the telephone piece is part of the logjam in the system. There's another piece of work we are doing about how do we set up, and we might come onto this in the transformation priorities that we're working across HHCP, is how do we are setting up across Hillingdon 3 what we are calling primary care access hubs to help manage that, help our general practice and manage that demand. Okay, so that's what we're doing. I don't quite how we answer the question. It's difficult to answer the question around do we know how many of people who attended at THH could have been seen in primary care. There is a process for NHS 111. If you ring NHS 111 and it is obvious it's primary care, that they can directly book you into appointment at your GP practice. But clearly lots of people, having had the experience that you have had, have just taken themselves down to the urgent treatment centre. So we don't quite know the detail of what percentage. I mean, maybe colleagues from THH might know a bit more detail than I do. But certainly if you dial 111, you can get an appointment direct. They make an appointment for you.
Patricia, what's your view on this?
So again, what I can't give you is an absolute number, but we absolutely, in the urgent treatment centre, which is the first line of entry into A&E, we have a system that operates with the GPs where we also redirect patients. So if we truly believe that patients would be better seen by a general practitioner, we've got slots for that. There are patients who come who may say, well, I've tried various ways, and actually it's not appropriate to then say you've come here and now we're going to redirect you elsewhere, but we very actively do redirect patients. So the patients that are coming through are mainly people who have an urgent illness or an urgent injury that need care, although absolutely accept that a number of those could be treated by their GP as well. But I would absolutely agree with Sue. I think what we're just seeing is a huge increase in expectation about immediate access for care.
And just, if I can, Councillor, just link back to, so what are we doing about that? Clearly there's been an increase in demand. So as Sue has said, part of our plan this year, as part of our transformation, is to bring live 3 basically same-day urgent primary care hubs in different parts of the borough to actually increase the capacity in primary care, because we know, you're absolutely right, we know that if people can't get a same-day primary care appointment, then they will turn up at the ED and the UTC department, because bluntly, they will, if they have to wait 12 hours, they will wait 12 hours because they believe we will at least get seen. You know, so that's why we're putting those 3 hubs in place. We believe it's around 20% of those ED attendances we believe we could redirect back to primary care with the initiatives that we're putting in place. We've looked at the numbers going into the ED department at THH, so that is our plan. But it'll also create the capacity in primary care that we're looking for as well to cope with the demand. So we are on this. We understand what needs to be done, and it's a key part of the hospital redevelopment programme, because obviously we've made some assumptions around the number of people who can be treated closer to home. So I think what I would like to do, Councillor, is obviously we plan to be one of those hubs live at the beginning of July and a second one at the beginning of October. So it would be good to come back later in the year just to see how those and the impact that those are.
You read my mind, Keith, because I was very. I think it sounds like a really good idea, but I think we as a committee would be really interested to know how is it working, because you know there can be a number of different seemingly conflicting truths. You know, that's so we're doing more GP appointments. Also, lots of people's experiences are it's not where it should be and what's going on, and there's spillover to other services, and I know the ambulance gets a lot of spillover as well, and obviously we exist in the world we exist in, but to get a real feel of what we're trying to do to improve that situation would be really good. So more information about those primary care hubs and how they're working, I think in you know, whenever you think's right, but I have a feeling, you know, maybe sort of towards sort of November time or something like that might be a good time, unless you get some more stuff beforehand. I've got a question before I bring in others, which is sort of related to this, because the draft future state operating model, which for those who are watching online, but you know, it's in the papers, it looks very good, but it looks incredibly complicated, and it looks like a very difficult piece to manage for it to work well. Now, one of the things that we find, obviously looking at the NHS, is there are lots of different parts doing lots of really great stuff. Sometimes there are issues with working together and things falling through the cracks and all this sort of stuff. This model, if it worked really well, I could see could make a very great difference. But then I look at this and think, how is it going to work well? So how is this model going to work well, Keith?
The slightly cheeky answer, you should see the current state. I couldn't get the current state onto one sheet of paper. So the complexity of current health services is a problem, because people fall between the cracks and they get bounced between services. So the model we've come up here is an attempt to simplify that and to think about things in 3 ways. And if I just focus on the left-hand side for those watching in at home, that's a bit of a difficult thing to see. But in terms of the neighbourhoods, what we are talking about there is making neighbourhoods the basic and most fundamental building block of how we deliver health and care in Hillingdon. And we are integrating a range of services which are currently very fragmented and run in separate ways. And the focus of neighbourhoods is around whole population health. How do we do more preventative work? Because we've become an illness and a sickness service, and we need to work more upstream to prevent people becoming ill in the first place. And then the third component is around the same-day urgent care, the conversation we literally just had, Councillor, about a couple of minutes ago, is how do we help those people who fundamentally are well, but they will have occasional acute illness? How do we help them to get the sort of care which allows people with long-term conditions to see their GP, because we know continuity of care is really important for people who've got multiple long-term conditions. So what we're trying to do is sort out something which has been a problem for 20, 30 years. And the bit in the middle is simply a way of integrating, again, there are over 30 services currently operate in that middle bit. 30 different services from health and care operating, and what we're talking about is bringing those down to 3 integrated services and joining up care more and using our workforce much more flexibly. So you're absolutely right, Councillor, it is a challenge, and that's why it's transformation. That's why it's not tinkering, because we can't go on as we are, frankly, and it does need this sort of change to deliver the sort of care that people want. So I have to say, I think as a place we're excited about this model. Clinicians have designed it, health, social care colleagues have been involved in it, and there's a real appetite for implementing it at pace.
My last question on that is, when do you think you can report back to us showing us the impact of this model? Because, again, it looks really great here, and I think, you know, direction of travel actually is very important. So my challenging question to you is, it is a very good answer that actually, compared to the current state, this is a better way of managing things and will be more better. But I suppose from our committee's point of view, we want to know when we should come back and question you about what's happening and the benefit that's made. So when do you think that would be a good time?
So our plan is to implement the first 9 priorities that we've got by the end of September this year, because it preps us for winter going forward. So at a time after end of September, Council, I think is the place to do, because we'll have implemented the same-day urgent primary care. We are doing a big piece, as Patricia knows, on discharge as well, and also starting to join those things up, so that we'll be able to give you some feedback in Q3 on how the first wave of implementation has taken place.
Great, look forward to that. So, June.
Thank you, Chairman, and thank you, Keith, for the in-depth way of how you're progressing and moving forward. But there's still a lot of concern about the GP services that is being provided. And yes, you have employed more GP, but there's some areas within the borough, and I'm speaking on my side of the borough, that has no GP service at all. So some services being addressed and other areas is not being addressed. The other bit I want to question you on is the 111 services. And I think we all experience some kind of issue somewhere along the line when you, rightfully, if you know you want to get a GP appointment in the morning, you have to be on the phone 10 minutes before 8 o'clock when the system is open before you can get through. By the time you press the button, at 8 o'clock, you got about 20 to 30 people on the line waiting to get an appointment. You said they can call 111 and be able to redirect and get an appointment. It doesn't always operate like that. And not only me, but I find other members of family and my neighbors, they all have the problem, complaining about the same thing. So getting, and there's people who are moving into the locality who's looking for GP is unable to register with the GP. So there is all different aspects and service within what is available for our residents to access. So there is this big bit you're saying about 111. When people want to see a GP or a doctor, they need access. They go to 111, all the questions is being asked and then is redirected. They don't always get that appointment. So what sort of advice and guidance would you give our residents who may be listening or who's watching, that they can move forward and feel comfortable that the service is really fulfilling their needs and requirements?
Thank you, Councillor. So I will take those in the reverse order. On the point that you made about people coming in to live in the area and not being able to register with a GP, at the moment, all of our practices have what they call open lists. We don't have any practices with a closed list. So if you as councillors are hearing about from some of your constituents around people who are struggling to get registered with a GP, please let us know, and we will make sure that we will facilitate support registration, because there's no practice with a closed list at the moment. Going back to the 111, essentially the advice and guidance, so every practice under their NHS contract they must provide appointments for 111, available for 111 to book directly through to them on behalf of their patients. And we do monitor that. The team does monitor that practices are making those appointments available to 111. I think there is something around really being clear about what you're phoning about and talking that through with the call handler on 111, so that it becomes very clear it's a general practice requirement really, and that your GP needs to be able to respond. What the response is, that the GP should ring you back and talk through, having gone through 111, talk through what the issue is, and then decide, either do a consultation with you there and then, or book you through for a further face-to-face appointment should the person require it. That's the 111. On the telephone thing, as I said, it is a real significant problem. I am really not underestimating it. We are rolling out the cloud-based telephony across this year, so we should start to see much more robust telephone response available for people, so that we unblock the 8 o'clock logjam that there is on GP telephones, so that it's not dependent on every practice just not having enough telephone lines or whatever it happens to be. That is the significant problem.
I want to take this opportunity actually to open it up, the discussion about Heathrow Villages, where June represents, because I think that is one of the areas, or the area, maybe Harefield might try and argue that, but it's the area where the lack of coverage is actually not acceptable, and it has been for a while. And I know everyone in this room knows that and has been doing stuff to try and improve that. But just in terms of a wider question, maybe CNWL as well. I think this interests you as well. What is being done to provide services down in a place like Heathrow Villages, where it seems to be hard to get health professionals to set up?
So we're working really hard on with the Heathrow Villages, actually with the Heathrow Villages. So a number of us have been out, have run sessions with the villages, and we're working with them to look at what services they need in those villages. And the reason why we want to go down the neighbourhood model is because actually there needs to be local neighbourhood solutions to some of these problems, where people either can't access pharmacy services or they can't access general practice. So that is a priority for us, and we are absolutely engaged with the Heathrow Village as we speak on coming up with solutions with them. And we ran an open session about a month ago with the villages, where a number of us spent half a day down there listening to the villages and what their issues were. And at the heart of the issues they raise, they have a point. They have a point in terms of the range of services that are available to. And it's something I actually think, I can only speak for health, we do need to do something about and to take seriously. And we've given the villages our commitment to doing that.
So, I mean, obviously, listening, engaging, thinking about solutions is all very, very positive in its sense. But I think what we want as a committee is really sort of maybe a pathway and an understanding of what's going to happen, because this is an issue I know June's raised a number of times, and I get emails from certainly a very specific fan of our committee who often gives me good feedback about what we should be asking about, but very true. So I think I personally would like to move on from the sort of investigation and finding solutions and talking, which is very good, and I would like to know what the plan could be. You know, in terms, I think that's what the people down there are crying for. So obviously I'm not expecting that to come right now in this meeting, but in future meetings, or when you're able to, you know, share that would be really appreciated.
Happy to do that, Jen.
Right. Philip.
Yes, I'll just echo that. I mean, we've been talking about challenges in Heathrow villages since I chaired the Health and Wellbeing Board, which is now nearly 4 years ago, and beyond that as well. So I'd endorse all that's been said there. Sticking with GPs and appointments, I know it's a bit of a theme this evening, and a slight variation on what colleagues have raised, and it's this question of that initial conversation that someone has with the receptionist and then the GP, and the sort of assessments, the sort of judgments that are going on around whether or not a face-to-face is required, which, as I understand it, is very much down to the GP. And I know COVID very much was a game changer. I'm interested in the figure for 2019, because that was the last full year before COVID, see how many face-to-faces we have then. But if you don't, that's not my main question. It's just observation, really. I think COVID taught us that we can manage without quite so many face-to-face consultations, you know, on Teams, by telephone, and that can work very satisfactorily. There are, however, members of the population who, for whatever reason, perhaps more disadvantaged people, struggle to articulate to the extent that others can, the extent of the issue, and I guess the risk that goes with that is that important things are missed, and perhaps some of those people end up pitching up and down, as we've just heard. So I guess we need a hybrid of sorts, don't we? Some sort of a system that really sort of manages those risks as best we can. And I'm wondering whether the hubs that we're hearing about, these urgent care hubs, are going to pick some of that up. And I do have another question related to GPs, if I may. Do you want to ask that question and come back and ask your very happy
question?
to, if that's easy, yes. So does that make sense? Okay.
So if I start, and then I'll pass over to Keith on the hubs piece. So this is not absolutely exact, but pre-COVID, the number of virtual appointments was about in the order of 5%. So, and then of course through COVID it went up to 100%. It's back. It's dropped right back down now to about 35%. That's about that. So your point is exactly right around needing a hybrid model, but having the right type of consultation meet the needs of the patient accordingly. And it goes back a little bit to Keith's explanation around the operating model and the neighbourhoods. As we begin to work, as Keith has described it, upstream a bit more, and our primary care hubs start to help try and manage the kind of day-to-day demand. So in that kind of day-to-day demand lends itself quite well to the virtual telephone or Teams, Zoom type consultation. It's those kind of immediate, what do I do about my child who's, you know, running a bit of a temperature type conversations. And leaving back in your practices people for whom their needs are more complex. A face-to-face is exactly what is required, and maybe a face-to-face with more than one member of the practice team within the same appointment. So they might see the GP, see the nurse first, and then go in and see the GP afterwards, and help manage and have the conversations around the whole complexity that patient and their family are dealing with, and allow the plan behind the hubs, as well as trying to help manage the upfront day-to-day demand, is allows to give the practices that capacity for that face-to-face consultation to be able to manage the more complexities. So it means the patient's needs are met, and they don't have to keep coming back and retelling their story. They're dealt with. So that's the plan and the thinking behind that more upstream proactive care.
And just, Councillor, just to finish that, what the hubs will offer, which we can't do in primary care, is access to diagnostics. And so it allows you to in terrible management speak, it allows you to close the appointment down at the point of contact rather than ping it somewhere else. So that's why this is transformative as opposed to anything else. It's thinking very differently about what we do. And I think, Councillor, we had a meeting with GPs last evening from Hillingdon, and being clear, the GPs are really clear that there are cohorts of people who have to be seen face to face. It's not a question. I mean, for example, children will always be seen face to face because of the really importance is you need to see the child in front of you, and there are other cohorts like that who simply have to be seen face to face.
Two more quick ones, if I may. The first one relates to the question of, I mean, we're talking about the neighbourhood model of delivery now. And I intend this comment, let me preface this by saying I intend this with great respect, but a lot of these terms can seem very much like management speak. I've been around a long time, I've heard a lot of different terms, and you never quite know whether something's been rebadged as something else, possibly that's broadly similar. We talked about primary care networks a while ago. Are we talking about something the same, similar? Is it a bit of a rebrand? What does it mean, and I guess what will people notice that's different? And then finally, if I may, just going back to the GPs, there are 42 practices in this borough. I know that the Fed aren't directly represented here, so I guess you're here in their stead, as it were. I just wonder if there is any information available about what's happening in individual practices where there are hotspots, challenges, performance issues. Is that information gathered? Is it available? Could it be useful to know? Thank you.
So if I can try and explain from a patient's perspective what the difference would be around neighbourhoods rather than from an organisational perspective. So if I drew a picture of how health service currently operates, it operates on bluntly, let's say there's a referral tag. So one professional group will refer to another professional group who will do its own assessment and then decide whether they're going to accept that patient or not, and it will move around. Around neighbourhoods, we're bringing together staff from many different organisations into one team, and what we're taking away is that requirement for referral and encouraging people to work flexibly around the needs of the person. It's also recognising that health services only contribute around 30% to a person's health and well-being, and then unless what we can organise our neighbourhoods are the third sector, community assets, such a dreadful phrase, but it's community groups, adult social care, all of those, it's those people coming together to work together around the person which make the difference. And if you speak to patients, if you speak to the Heathrow villages, not only will they tell you we've got no services, they will say, and actually, it's fragmented. We can't get a joined up answer to it. And that's the problem we're trying to solve, is to join things up for people so it's focused around their care. And Councillor, conversation we had a number of years back, 5,000 people in Hillingdon contribute to 70% of health resource. We know who these people are. We need to do better for them and join things up more for those people, and that's what Neighbourhoods is intending to do, and that's why it's so important going forward, and why we're so committed to making it real.
I'm sure we all very much look forward to seeing that in practice and hearing about it at a future meeting. Thank you.
And picking up your question around performance, so yes, primary care networks are still a thing, and they will work in with the neighbourhoods exactly as Keith has described. On the performance piece, through the COVID period, and for a little while afterwards, the Care Quality Commission kind of stopped all inspections. They did continue to phone practices and all the rest, but they stopped all inspections. They've all started up again, the results are nationally published and available. Associated with that, the Hillingdon primary care team that works with all of our practices are beginning to kind of set up again, which we had pre-COVID, a system of visits to our practices and just following through, supporting, trying to unblock any issues and all of that. And yes, we will have that information alongside the CQC available information. So that will be available as the whole system of review, I suppose, sets back up again.
Thank you for that answer. It'd be good to see that if there's an opportunity without making it an onerous process to assemble. So thank you.
It's not. It's starting back up now. I suppose, Chair, the issue is the kind of timing of when we might start pulling some of that information so that we have it available for a report back to the committee.
I suppose from our perspective, when we know that it's likely to be, Nikki can chase you. So if you can let Nikki know when that's likely to be.
I should have said in due course, shouldn't I? But yes, thank you.
So so even if it's not ready at the moment, but you think it might be ready, didn't let Nikki know, and then Nikki's excellent at chasing, as everyone here knows who's here tonight. Lisa, you wanted to come in at this moment, yeah.
Thank you, Chairman. So with regards to GP access, I mean, this is the issue that we hear about the most at Health Watch Hillingdon. And yes, whilst there are people often reporting long waiting times on the phone, actually I find that most of the issues stem from communication, and obviously lots of great work being done to try and improve the issues around access, and obviously digital has made a difference to a lot of people, but I think there's another piece of this which is about managing patients' expectations, and that actually the model moving forward is to make sure that those people that really do need to be seen face-to-face will be seen face-to-face, because I think a lot of the reason people might be going to A&E is there's now some distrust with services that people may not get an appointment. So I think there's definitely some work to be done around communicating the direction of travel and obviously the reasons behind that. I think that would be really helpful.
Yeah, I think that makes a lot of sense. Rita, you wanted to come back in.
Yes, so one final question on GPs. I know we've talked about the hubs and the telephony and the cloud for etc. I think the other issue we've got is not just the telephony waiting time we have, but the forward planning of appointments. So if I phone up today and say, I'm working, but can I have an appointment on Wednesday, Thursday or Friday, and I can plan it into my diary at work, the GPs aren't offering that service. Oh, you have to phone again tomorrow morning at 8 o'clock or 2 o'clock. Why? So will the hubs be looking into that to say, can I work around working, schools, mums, parents, everybody, that I can book an appointment in 2 days' time? Because there might not be an emergency now, but I would like to be seen or have someone call me in 3 days' time. Is that something that the hub will be able to offer?
I think in terms of the hub, we're still in the process right now of kind of working through what the actual model will be in terms of responding and booking through appointments and all of that kind of thing. Largely, I think it will be about dealing with whatever is coming through. It's same day. The hubs are really much more focused on issues that need to be sought out in that day. People phone up, get their response that day. If the patient does need a GP appointment face to face back in their own practice, the patient will be sent to their practice for their appointment. I completely take your point around forward planning of an availability of making appointments. You don't need to see anybody today, you need to see them in 3 days' time, and that is something goes back to your colleague, the Councillor, question around the performance. So part of what talking to practices, going out and visiting them, and is about supporting them, thinking about that forward planning of appointments and putting systems and processes in place in practices so that they can think about that forward planning of appointments. So yes, they deal with the same day, but also they deal with the stuff going forward, and that is absolutely on our agenda.
I think the point Rita makes is a very good one, because my experience, anecdotally, appointments are either available on that day, if there's space, or 15 days ahead. It's like famine or feast in that sense. And feeding into Lisa's point about communication, because of course communication is two-way. My understanding is that GP practices are meant to have sort of patient boards above them or something that feed back into all this sort of stuff. Now I wonder how effective that system really is, because if people were feeding back into the point that Rita made, then maybe they could adapt their practice. But is that communication really happening? Do these patient feedback boards, for example, I don't even know what they're called, do they actually make a difference? Are GPs hearing about experiences such as Rita's described and thinking about how to change those? Do you know anything about how that sort of feedback loop works?
So there's two ways of the feedback loop. There's the annual national patient experience survey, a random selection people. I think it's I can't remember the national provider that actually runs it for us. Just off the top of my head, I can't remember. And that does detail a lot of patient experience questions, including exactly the question you have raised, Councillor, around forward planning of appointments and that thing. So yes, practices do get that feedback, and they get that feedback by practice. And we get the feedback by borough. We can see it by borough. The other thing you are referring to, Councillor, is the patient participation groups in each practice. And yes, each practice is expected to have a patient participation group. Communication does go two ways, and some will be more effective than others. Some where the practices really engage their patient participation group and their patients want to be part of such a group, that kind of communication does go on. In others, practices struggle to get their patients to be part of such a group and want to engage in those. Some practices have e-patient participation groups and try and different ways of engaging their patients. But yes, patients are it's often a very small cohort of people who want to be on such groups, and the vast majority of the patients registered with the practice, don't really want to get involved in that kind of thing. So it is quite hard for the practices. It is trying to make that communication go both ways to allow that dialogue and do something, sort out something like forward planning of appointments.
No, I completely understand that. Interestingly, the national survey that you mentioned in terms of the borough data, again, I think that's something useful when it's available and possible to share with us. I think we would find extremely useful. Keith and Sue, you've been talking for a long time, which is always the problem of going first in these things, but very interesting. So I've got Tony and Barry who want to ask questions, and after that we will definitely move on to Patricia. So, Tony.
Thank you, Chairman. Just a very quick one for me, really. This operating model, is everybody buying into it? It sounds great, and if it works, it works, but if is everybody going to be part of that cog? What is going to happen in Heathrow villages, for example? Do we know yet? It sounds really good. I'm really impressed with it, and if it works, great. But are people really buying into it? Because I know they can be a stubborn bunch. Some of the health services, and there's a bit of rivalry as well.
I don't know what you mean, Councillor. So the model that we've developed, and I could look at Patricia. Clinton was on the workshop where we designed it. Patricia, so clinically and from a local authority point of view, we've spent the last 2 or 3 months working on this model. It is as owned as any model that I've ever worked with in the NHS, because it's been designed by frontline staff to say this is what we believe will work. And the answer to your question, is that but what the NHS is never very good at and I've been working in NHS now for nearly 30 years, so I can own up, is implementing things and doing it effectively. And that's the challenge here. We need to implement and do it effectively, so I can come back here 6 months and say, it's worked. Now, we have done it before in Hillingdon. I mean, Patricia's admission rates and elective admissions have gone down. And they've gone down because of the changes we made 3 years ago, and they're the lowest in North West London. So we can do this. But I think the proof of the solution for Heathrow Villages, I mean, and I'm sure Heathrow Villages are listening to the call now, actually is in that neighbourhood working, because they should have had solutions a long time ago. But you can't solve everything at a macro level. You just can't. It needs local solutions. So I am confident that if we implement this model correctly, we will see the benefit, and it's got huge buy-in. We've talked to GPs about it yesterday, so we're doing a lot of work on this one. So I've got every confidence if we implement it properly.
We do wish you every success with it. I look forward to hearing about it again more. Barry.
Yeah, my question has nothing to do with GP appointments, you'll be thankful. Yeah, I like the idea where the healthcare partners have got a collaboration of different things, the ICS and the ICB. My question is, can you tell me more about the survey for the community eye health services, which has been done with Brent, Harrow and Hillingdon? So could anybody could answer that question? I'll just...
tell them the page.
No, it's just reading an email. I just had an email sent to me, that's all, 2 days ago. And about the North West London ICB, Brent, Harrow and Hillingdon. And they're doing community eye services between Brent, Harrow and Hillingdon. And the survey.
Barry, would it be okay for you to share that email with Sue?
Yeah.
You want to share it across?
Councillor, this will be the primary care eye service. Clearly, we're right in the middle of, there's a whole piece of work happening in terms of reviewing the community eye services that are currently provided. And as part of that review, a survey is being carried out, and clearly they have asked you and colleagues to respond to the survey, and the outcome of the survey will feed into how community primary care eye services are delivered in the future.
I see.
I think what's interesting, Barry, is that's something we've never looked at in this committee, is it? So I suppose it's something that maybe for Nikki to note, that when the data's back and they understand what this might mean, I think we as a committee might want to look a bit more in depth into that.
So your question, Councillor, is very timely. On the 1st of April, NHS England this year, NHS England delegated commissioning and contracting responsibility back to the ICB for dentistry, eye services, ophthalmology and pharmacies, high street pharmacies. So we're just right in the moment of taking that responsibility for contracting and commissioning those services back from NHS England. They've been with NHS England since 2013. And I'm sure at some point in the future, coming back and reporting back on those primary care services as well as general practice services would be, we would be happy to do that in a future meeting.
That sounds really interesting. I mean, we've looked at dentistry, for example, in the past, and all those free services. Obviously, we can talk to you about it, and we're going to look at our work programme later. But you know, if you think it's sensible, June or July, you know, to hear more about what that actually means in reality, because certainly from dentistry that we've looked into, I think having a more locally based sort of model would I think benefit a lot. Cause some of the problems we did come across was the agreed ways of funding dentistry was just, I'm going to say mad really, but outdated and no one wanted to change. So maybe hearing more about that in June or July would be useful. So that'd be interesting. Okay. Right. Okay. Keith and Sue, thank you so much for going first and speaking for probably more time than anyone else will speak, but very interesting, and we look forward to hearing more about the progress you guys are going to be making. Patricia, can you give us the update for Hillingdon Hospital?
Happy to do so. And so just to start by saying, what I didn't do was circulate our full performance report. Sorry, my phone's talking to me. The performance information, in fact, we've only been through the year-end performance report today, but our performance reports, which is about 79 pages long, is on our website. Everybody is welcome to look at it. It's always published every month. And what the committee might be interested in looking at is that through the North West London Acute Provider Collaborative, we also have a performance report that is seen at the board in common. And that actually gives a comparison of Hillingdon Hospital Trust against the other three trusts, the acute trusts in North West London. So actually it's very nice now that we have a position where not only can we show what we're doing as an organisation, but we can compare and contrast with other acute providers. And in that respect, we are, without a doubt, holding our own, which is good.
So is that public and on your website?
So you need to go to the North West London Acute Provider Collaborative.
Okay.
If you just Google that, it takes you to that website, and then it takes you a link back to our individual website.
Because I'm going to ask Nikki to send the link or links to all of us. So either you can use the power of Google or you can ask somebody. But obviously as a committee it'd be useful for us to have those links so we can look at them whenever we feel like we need to. So that's really good, thank you.
And the other bit of context is just to say that as a provider we have a number of what we call the operating plan targets, which I've predominantly focused on in this presentation. We also monitor a huge range of indicators within the organisation about just our operational practice, how we monitor health and safety and all of those sorts of things, and that information is in the performance report, but I haven't particularly pulled it out for tonight. So in the context of where the trust has been, and I know this committee has had concerns in the past about the performance of the organisation, both from a quality point of view and a financial point of view, I suppose my summary for 22-23 is that we've very much focused on performance and becoming a more sustainable organisation, and I'll just pull out a few points around that. But our key activities have been around developing a new 5-year strategy. People talk a lot about the new hospital for Hillingdon, but it will be 5 years as a minimum until we have a new hospital. And what we need to do is we need to make sure that we're continually improving quality and our financial performance as we move towards a new hospital. So for me, it's a milestone, and it will be a very positive milestone for the hospital, but we're not going to move into a new hospital without having changed practice and making sure that we're an affordable and high quality service. The focus in the NHS over the last couple of years has been how we, coming out of COVID, move activity and performance back to what it was in 2019-20, and that is absolutely the mantra across the NHS. So what were you doing in 1920? What does that mean for now? I think it's important to understand that 1920 may not be a perfect year, in that, you know, we absolutely recognise as an organisation that at the end of 1920 we had a 36 million underlying deficit in terms of finances. That was not a good place to be, and at the end of 1920 we'd had a CQC inspection in 2018 that had serious concerns about the performances of the organisation. But in terms of, is the NHS getting benefit for the income or the money that is committing to the NHS, is it getting the same level of productivity as it was in 1920? And that's what we've been working toward. And I am pleased to report that we are broadly back to where we were in 1920 in terms of use of resources, and making sure that we're delivering. And that's been a steady increase through the year, so it's not that we achieved that for the whole of the year, but I can report that for the last quarter of the last financial year, we were doing somewhere between 107 and 111% of the activity that we were doing in 1920. So that's a really positive place to be. We have delivered on the national elective recovery targets, and I'll come on to that in a bit more detail. We're not delivering where we would like to be in terms of urgent and emergency care throughput through the A&E department in 4 hours, but we are broadly on par with other trusts. So in a way, it's not a good place to be, but we're not out of line with other organisations. We've seen some small improvements in our staff engagement. Our staff survey is in line with where it's been for the last couple of years. We've seen a small uptick in our staff survey and our staff engagement, but we're not seeing the big improvement that we would like. But again, we're largely on a par with the NHS in general. And we've done a lot of work on some key strategic programmes and on developing partnerships. And I think some of the stuff that Keith has said is very much around how we develop partnerships. So in the pack that we sent you, and apologies, I've realised that I didn't take off my comment, which is kind of have a few bullets under each of these, so that relates to the next pages. But I think what we have in our strategy for the next 5 years is very much the things that you would expect to see from an NHS organisation. So it's an absolute focus on quality, a focus on our people, because we will not deliver high quality care unless we bring our staff with us. A real focus on performance. We have to do that within the financial envelope we have available to us. And we are really clear as an organisation that we can only do that through developing really strong partnerships. And we are a small to medium-sized district general hospital. We will not go away. We will always have an A&E in this area. We are the receiving hospital for Heathrow. But there are some services that we just cannot. It's just not cost effective for us to provide on our own. So we'll have network services, we'll have franchise services, and there will be some services that we will do in partnership with other organisations, and not just with the acute sector. It will be in partnership with the Mental Health Trust. It's in partnership with our GPs and our voluntary sector, and that is absolutely the future for the organisation. And we've got a few strategic programmes that I'll come on to that are about really big things that we're delivering in year. So we started last year saying that we would have a financial deficit of 5.6 million. We delivered on that. We have got a much more stable financial position. We understand our financial position. And as we move into this next financial year, we have accepted that it's not just a financial deficit that sits with the Acute Trust. It's a financial deficit that sits at place and across the partners at place. I am pleased to report that we've had a 6% increase in productivity over most of last year, and our bank and agency spend, which is an indicator of quality of care, because if you have less permanent staff and are spending more on bank and agency, it's much less easy to guarantee the quality of the care you're providing, and our bank and agency spend is back now to below the 19-20 level, so that's a really positive place to be. And in fact, we've reduced our vacancy rate significantly, and particularly for our qualified staff. So we did a big piece of work last year around international recruitment and have brought our vacancy rate for our qualified staff down very significantly. In terms of the elective recovery targets, our target was that by March or the beginning of April 2022, we'd have no 104-week waiters. That is absolutely the case. Where we've had odd blips in months, they've all been dealt with within months. We reported that we would eliminate 78-week waits by the end of March. We had 6 patients at the end of March who we were not able to treat within the 78-week target. In part, that was due to the industrial action in March, and actually all of the 6 patients were patients who we were able to offer appointments to, but through patient choice they didn't wish to come in by the end of March. And we are on target by the end of April that we will have, and today I heard there's a risk of maybe 13 patients who will not get treatment by the end of April. We hope that that will be no more than 2. So every patient has an appointment that they can access. And we've made some significant reductions in the number of patients waiting over 52 weeks, and in this year we have to eliminate all patients who will breach 65 weeks, and we are already on target for that and have a very rapid trajectory around that. So I hope there's a lot of hard work in this, but I hope it gives a much more positive picture than perhaps you've heard in the past around what we're doing in the Trust. Our urgent and emergency care performance, a couple of things to say. So the national target has changed. So we were expected to operate to at least 95% of patients being seen within 4 hours. The national target for 23-24 is that by the end of 23-24, 76% of patients should be seen within 4 hours. So it is a drop at a national level. Across the Acute Provider Collaborative in North West London, we've agreed that we will aim to achieve a higher percentage than that. We have had a number of months during 22-23 where that target we haven't even achieved 76%. As I say, it's not a good place to be. I personally believe we should continue with a 95% target, but we are very much in line with London in general and with the national position, so it's a very unsatisfactory position for patients who need urgent care. But we have seen an uptick during February and March and through into April. So it's a bit variable on a day-to-day basis, but we are maintaining above 70% performance and on a number of days seeing above 80% performance. So that's encouraging. We did take over the management of the Urgent Treatment Centre in February, and now that is managed under our control. We are seeing improved performance across a number of sub-indicators, so patients being seen within 15 minutes of presenting to the department. We've seen a big reduction in our ambulance waits and handover times, so there are a number of indicators within A&E where we're starting to see some big improvements. I think the area that I probably have most concerns about is through our cancer performance. We have some very complex pathways because we refer to lots of different organisations. We don't provide a lot of the cancer care ourselves. So in some areas we have really high performance, and in some areas our performance has been poorer. Our 31 and 62 day waits, we've been working very closely with Royal Marsden Partners, which is a collaborative of cancer centres. And they have absolutely recognised that we've reduced our backlog of patients waiting a long time very significantly, and they've just given us additional resource to help us manage that pathway in a lot more detail. So I think we'll see even more improvement into 23-24. Very quickly, we've continued to focus on quality improvement through the year. As a committee and as a local authority, you always comment on our quality priorities. We've done some very good work against our quality priorities. We haven't met all our targets there, but a number of those we're carrying on into this next financial year. A big focus on understanding and making sure that patient experience is much better than it has, and I know we've been talking to Health Watch about that. We've done a lot of work around our internal peer review and our internal way of monitoring quality, because actually the CQC has changed the way it inspects organisations. We are not being inspected in the way we were in the past, so we put in much more local peer review, and we've done a gap analysis against the CQC targets. We're doing things called quality rounds. We've got ward and department accreditation programmes, and we're doing peer reviews amongst the acute trust. So we've just done a peer review of our urgent and emergency care services. We're doing peer reviews around our discharge planning, and we will do more around that. So I think I just wanted to highlight some of the internal work we're doing. In terms of improvement in staff engagement and health and well-being, we have a number of health and well-being programmes in place. We've done a piece of work across all of the organisations in North West London and have a very comprehensive set of programmes that staff can access. We've done a lot this year around staff recognition awards. A lot of that got stopped during COVID, and it's been really great to be able to bring that face-to-face kind of ceremonies and award ceremonies back. And we had an absolutely brilliant event at the Bunker, which the Mayor came to. And staff, I think it makes you realise how important it is to thank staff. You know, we do it on a regular basis, but people are so chuffed to get an award and bunches of flowers and photographs taken, and it really was a lovely, lovely event. And we're doing a lot more around thank you vouchers and open days. And just a bit of a plug, we will be having an open day on the 8th of July on the Mount Vernon site. So we had an open day at Hillingdon last year. We said we would do it at Mount Vernon this next year, and there will be an opportunity for the public to come, but it's also celebration for staff. And in terms of our staff survey, it isn't where I'd like it to be. Actually, the NHS staff survey is not where we would like it to be. And we will be doing, we have done a lot of work this year. We saw some small improvements in areas that we've given particular attention to, but we have absolutely agreed we will do more this year. We want to turn the mood of the organisation around, and particularly where staff say that they wouldn't recommend the organisation as a place to work or a place that they would want friends and family to be treated, and that for us is really important. I'm not going to say too much about the strategic programmes, I'm conscious of time, but we have 3 big things that we are we've focused on. The digital programme that takes us into next year, but we are implementing a new electronic patient record system. It is a massive piece of work this year. There will be masses of benefits from it, but it's a big change programme, and we will be implementing that in November. The redevelopment work, there's been a lot of work around the redevelopment. I'm really pleased to announce that we got planning permission for the new hospital, but there are lots of issues at a national level, so we haven't been given the go-ahead for the next phase, but we're confident that we will get that and that we can take the next phase forward. And then in terms of sustainability, I'm actually really proud of the fact that we've done some great work on sustainability, and we've won a number of national awards on that, and you can't move for Green Apple Awards in the Estates and Facilities Department in terms of our awards. I think Keith has touched a bit on partnerships. There is a slide in here about the work we are doing in partnership, and that's very much about stuff that's being done at ICB level, what we do on our own as an organisation, what we're doing across the Acute Provider Collaborative, what we're going to do in terms of, we've been working very closely with Chelsea and Westminster, and we are going to continue that strategic partnership with Chelsea and Westminster for positive benefit for both organisations, and I think really importantly we're going to really strengthen the work we're doing with HHCP. So the comment about, you know, why are we sure that we'll be able to make this complex diagram less complex, because we are going to work together on that. So in terms of 23-24, it's going to be more of the same, but at a much higher pace. Big ticket items are our Cerner Go Live. We have to continue to make reductions in our financial deficit, and that means we've got to be able to show that we're doing things more efficiently, that we're more productive. And a lot of what we do is about how we change our pathways of care and make sure that actually patients only come to the acute trust if they need to come to the acute trust. We absolutely have a focus on reducing the elective backlog. Patients are waiting too long for care. And we will do more work around the next phase of the decant and enable, which is the clearing the hospital site so that we can put the new hospital up, and a real focus on our staff. So thank you very much. And I'm sure it was more than 6 minutes.
No, that's okay. I mean, hospitals do so much, and no, thank you, Patricia, and it's useful for you to mention extra sources of more information as well on your performance as well. I have one question. It's about your gap analysis against CQC, possible possible inspection, because obviously I know it's in some senses a paperwork, but in other senses a very important piece of paper, and I think as a borough we're looking forward to, hopefully when the CQC can look at us again, to see hopefully that we are improving as a hospital. So how is it looking? If the CQC were going to do a full inspection, or next day or whatever, what would your reaction be?
So we had a bit of a test of it. So we did a gap analysis last spring and summer, and we have a governance structure through the clinical divisions where they are continually monitoring what they found at the gap analysis, what they've done about it, and things like our peer review visits and our accreditation visits give us a bit of a temperature check on where we are against that gap analysis. So across all of our divisions we've seen improvements in terms of the accreditation, which gives us a sense of where we're going. When they came, so we had an unannounced visit to the medical wards in November. That was in part due to some concerns that had been raised by members of the public around complaints that we'd responded to, but members of the public felt that they either hadn't been given a full response or that they still had concerns about some of the issues that were being raised. We got some really positive feedback about what we'd done. So I think it's fair to say that based on that feedback, I would be reasonably confident that certainly the areas that we were scored as inadequate the last time, we would not be inadequate this time. We did get a compliance order, but that is in part because the CQC now, if you get any major concerns, they have to put some kind of licence condition against it, which is not what they used to do in the past. You could have a major concern and you just said, we'll have dealt with that within a month, and that was how it was. But their concern was actually about how did we share learning across the organisation, so they could absolutely see that if they went to a particular ward, people knew about an incident or a complaint and could explain what they'd done about it. But if they went and asked about that particular complaint on another ward, they might not know about it. So their concern was, how were we disseminating the learning across the organisation? We've absolutely taken that on board and recognise that there's more work to do on that. And in fact, we had some feedback on the CQC report today, and the general feeling was that the individual divisions had done some really good work, but now they needed to make sure that triangulated across the organisation. So I'm not going to post anything to the flag or whatever the expression is, and say I absolutely would know, because CQC visits are very dependent on what they see on the day. But I am absolutely confident that the work that we've done around quality and what we can see in our performance indicators shows that we've moved a long way from 2018, without a doubt.
So, thank you. Philip.
Yes, I mean, the first question I think you've asked of mine, Chairman, so I'll move on to a couple of other ones. I think I'm right in saying that the discharge situation is in a decent place compared with other authorities. Just wondered where we got to with delayed discharges for after hours, weekends, that sort of thing. Certainly we spoke about it, certainly in my time going back 3 or 4 years. It was quite a challenge then. I just wonder where we are now with it. How much of a challenge do we still see it as? How much of an opportunity is it? And I'll that question first, and I'll come up with another one. Yeah.
So actually, we're now monitored in a way that we were never monitored before. So we have to do returns every single week of how many patients were fit for discharge, and we now have 4 sets of criteria. So those discharges that are absolutely under the control of the trust, those discharges that will need some community intervention, those discharges that will need full social care intervention, and so very strict criteria are measured against. We have to record every week how many patients fitted those categories. We then also have to report on how many patients were discharged before 5 o'clock at night and how many patients were discharged after 5 o'clock at night. So we perform very well for discharges before 5 o'clock of the people that were eligible to be discharged, if that makes sense. Do I think we could do better on that? The answer is absolutely we could. We have a number of examples where patients were fit for discharge, but because they were waiting for transport or various other things, they were discharged later in the day. But we do perform very well in terms of that 5 o'clock cut-off.
Okay. Thank you. Yes, I suppose it was really about the social care interface with the hospital in that regard. But thank you for that. The other question I have, and this is anecdotal, it's something I picked up a while ago, and it may nothing scientific about it, but I happen to know a couple of older residents who had a stay at the hospital some time ago. They met a number of older residents who were there as well, and I suppose you would call them people who were suffering with chronic loneliness. Very little social contact, actually welcoming being in a place where they have some human contact. I did wonder about the strength of the relationship with the voluntary sector in the guise of Hillingdon for All. I think that might be called something else now, but I think you get the drift. Because there didn't seem to be a lot of... When I asked about what information there was about how joined up that was and where there is source of contact information about befriending and all that sort of stuff, there didn't seem to be a lot. So I don't know, is that a fair characterisation? How strong is that sort of interface? Because what we want to do is prevent readmissions of those same older people, and I just wonder how strong that is at a hospital level, at ward level.
If I can go back to your previous question, because you made a comment about social care, I just want to be really clear. I think we have a really positive relationship with social care here, and there was a lot of work under the Better Care Fund during COVID about getting patients to other places of care whilst care packages were being sorted out. that money got withdrawn, but actually in Hillingdon we continue to maintain a really strong relationship, and that absolutely is why we're performing as well as we can. So I can't, I think we discuss this a lot, but I can't thank the local authority for your openness with that, and I think it says a lot about the way we work together. In terms of your second question around, how do we signpost to other services? We have a number of services that are available in the trust, so British Red Cross will take patients home and make sure that they're settled in. We have a very strong relationship with the voluntary sector, but actually I think it would be fair to say I don't know how much we say to patients when they're with us, and by the way, when you go home, there are these other services that you might want to access. And I will pick that up. I think that's a very valid point. There is a second issue for us, which is we have been trying to strengthen the number of volunteers we have, particularly around support to the clinical services, but also wayfinding for patients, being able to go and chat to patients on the wards, those sorts of things. And we've been quite successful, and actually we've been quite successful about recruiting some younger volunteers as well, which has been helpful. But we absolutely and utterly need to do more work on that. And I'm now going to have to admit that I can't remember her name. Your other councillor colleague on the Health and Wellbeing Board. Councillor Palmer.
Oh, Councillor Palmer, yes.
So Councillor Palmer and I, because Councillor Palmer sits on the ICB board as well, and we had a presentation about volunteering, one of the last meetings, and she was talking about actually some of the really good work you do in Hillingdon around volunteering. And the last time I was at the Health and Wellbeing Board, I asked if once we were through the industrial action and things like that, if we could have a bit more of a chat about what we might be able to do together on that. So
I think what's interesting is something like loneliness is something obviously we all hear about being a great impactor on health and well-being, and Philip's example is a really great example of that. So yeah, some sort of way that information can be disseminated easy for those sort of really key big things that we know are issues such as loneliness, I think could be beneficial, because if somebody's happy to go to hospital because it means they're in contact with people, obviously that's great for them, but is it the best use of our resources, and can they actually get that in a better way? So yeah, I think that's a really interesting idea. Okay, right. June.
Thank you, Chairman. My concern is about, I know we're waiting to see whether you get the funding for the new build and everything, but at the same time, Hillingdon Hospital has got a lot of structural defects and in the wards that people are placed in. How are you getting on with that, and how is that being covered to enable individuals who come into hospital to feel comfortable that they're in a safe space to be treated? Because I know that was a big concern previously of the buildings that's on the premises not up to the standard and requirement for people to be treated into. So can you update us on where you're at with that?
So one of the primary concerns at the Trust was around fire safety, and in fact we've had a fire improvement notice for some time now. We are waiting for the fire service to remove the fire improvement notice, because actually we've met all of the standards that they needed us to meet. So what you will see is in the tower block particularly, which is our high risk area, we've completely refurbished, we've taken out asbestos, we've put dry risers in, we've improved our lift service, and we've done a lot of work on what our evacuation procedures would be. So a lot of work on that, and not just in the high rise, but across the organisation as a whole. But obviously it's easier to get out of buildings if they're ground floor. So that health and safety aspect is has been very important to us. In terms of the fabric of the buildings, we have an annual capital amount of money that we can spend, and we have an absolutely clear maintenance program about making sure that we are replacing faulty equipment, replacing boilers, doing all the electrical checks, all of the things that might be hazards in the organisation. Do we have enough money to do all of that? No, but we also have to balance given that we will have a new hospital about, probably keeping some of the buildings going without spending a huge amount of money on them. The other area is that as part of the redevelopment programme, we have what we call a decant and enable money. So we have had a considerable sum of money from the national pot, which is about allowing us to refurbish or create new buildings that will be temporary buildings as we move towards the redevelopment. So, for instance, our ITU, our respiratory ward, our children's ward, our stroke services, they are all in new modular buildings, which are absolutely state-of-the-art buildings. And very happy if councillors want to come and look around them. We'll be very happy to show them around. We have to kind of balance up that we don't want them to be too sparkly because we still need a new hospital. But they absolutely have a limited life. But they are completely different facilities to what you've seen before. So we've had funding to do that, and we are hoping that we will get the next tranche of decant and enabling money, which will allow us to do up the FIRS, will allow us to move the creche, will allow us to do up the education and training facilities, so that we can then clear the part of the site where the new hospital will be. So actually we're in a good place, because a lot of trusts that are doing new builds are just being told they have to wait until they get the money for the new build, whereas the way we've negotiated it is that because we need to clear the site, which will allow us to build very quickly, actually we need new facilities whilst we're doing that.
I like the fact we're getting them to give us money already, because it means they've already started investing. So hopefully that'll help us when they finally come to making a decision on the full spend for a new hospital. Tony,
just a quick question again. Just heard a report the other week on the news about the growing trend of more mixed wards, mixed sex wards. Are there any mixed sex wards at Hillingdon? No, I didn't think there was.
So, in fact, no, I don't think we have anywhere. I was going to say ITU would be the only place, but we don't, in fact, because of the way our ITU is structured now, that we don't have to mix sexes. You are allowed in assessment areas to have mixed sex areas, because you're there for a period of time. So, for instance, A&E is mixed sex, because you put the patient to the most important area in A&E, be it resus or in our what we call our red area. But no, we don't. It's actually very reassuring that we don't encourage mixed sex wards.
Thank you very much. That's reassuring to hear.
Thank you. Barry.
Yeah, this question is to do with the North West London Acute Provider Collaborative, and it's only been going to early doors yet, but the orthopaedic thing, how's that running at the moment? Is it going well?
So, as you're all probably aware, there was a full consultation on, so there is a national programme to move to more elective centres, because the evidence is that if you consolidate particular services in one area, then you get your surgeons working together, you get expert teams together, you put volume through that. That means you do an awful lot more learning. And if you take places like RNOH, or in the case of South West London, Swellyock. Swellyock's been running an elective orthopaedic centre for, well, I ran it, and that must be nearly 15 years ago, maybe slightly longer than that. So you absolutely see the benefit of that. You get reduced length of stay, you get reduced infection rates, you have much better information to audit care and can respond quickly if care looks as though it's out of kilter. So there is now a national directive that we should be moving to elective centres, particularly for high volume turnover patients. So there was a piece of work done about creating an elective orthopaedic centre for North West London. That consultation is now finished. The plan is that we will move to having an elective orthopaedic centre at Central Middlesex Hospital, and there's been lots of discussion about, particularly for patients in Hillingdon, how we make sure that they've got access to there. The work that's going on at the moment is around, okay, so how do we make sure that the care pathways from every organisation in North West London are as smooth as they possibly can be? So we're really clear that the majority of patient care will occur in Hillingdon. So your outpatient appointment, your pre-assessment appointments will all occur in a facility at Hillingdon. You will go to Central Middlesex Hospital. You will be operated on by the consultant who you saw in Hillingdon, unless you've opted to just be operated on. If you want to be seen earlier and you can be operated on by one of the other surgeons, you can do so. You'll have a short inpatient stay at Central Middlesex Hospital, and then your post-operative care will either be in the community, in fact, because a lot of the physiotherapy can be community-based, or and your outpatient follow-up will be at Hillingdon. So we're now in the phase of planning what the next stage of that looks like and how we make sure our referral pathways work. But I think it will move at pace now. We expect that patients will start to be seen at Central Middlesex Hospital from October, but it will be a gradual transition. So not all Hillingdon patients will be seen there by October. It will be a gradual transition through this financial year.
I mean, I think when we looked at this, we thought it was very good in many ways, but the big issue is transport for those who aren't able to have someone drive them, pick them up, because using public transport if you need to have orthopaedic surgery is basically almost impossible, really, and taxi fares quite expensive potentially as well. So we have fed that back in. I know our cabinet member Jane Palmer has also fed that back in as well. So we have been told that is being looked at and a solution will be given. So we're just waiting for that solution. Right, excellent. Are we okay to... Oh, June, go on. One more, June, before we move on.
And Sue, because I've missed this, I just wanted you to give me some guidance on the bowel cancer screening. And you, in Hillingdon, you've got 51%, the lowest rate in South London, among the BAME community. What are you doing at the present time to get that number up and your contact rates with the residents and how you're going to address it? Can you answer that? And one more, I'll give you the two together, so not the whole thing. And the hypertension rate, we've got BP monitoring in all libraries. You said you're going to have BP monitors at all libraries and community areas. I am aware they are in GP services, which I'm very glad to see. But when you said in libraries and in other community areas, which part of these areas are you going to put it, and how are you going to let the public know that it's there? Because it's a good thing to have people who are able to go and monitor their BP by themselves, and if they see any irregularities, they're able to contact their GPs to say, well, this is the problem, because hypertension is one of the biggest disease among people at this present time.
So if I pick up your question, thank you, Councillor, on the bowel cancer screening. So as I said earlier, the performance report that you have in your pack was the February one. So I have had the March one as I was preparing for tonight's meeting. So just to let you know that the March data, Hillingdon's performance has improved from 51% to 66%. However, we are undertaking key actions because we recognise this is still low. And the key actions include, one of the things we picked up was that targeted work with Brunel, the GP practice at Brunel, lower rates linked to our student population because they have a younger population. So part of the issue is that younger population registered with that practice is kind of slightly skewing our data. But we are picking up actions with that practice. We are also, through our practices, sending free text messages reminders to patients who don't return their fit tests, the tests that come through in the post. And we have got lots of links which we developed through the whole COVID period around COVID vaccination. We developed using volunteers lots of community links link workers, and we're using them to contact patients. They are going out and contacting patients who haven't responded on behalf of their practice, who haven't responded to screening invitations, linking in particularly to the BAME populations who have higher incidence of bowel screening rates. So there's a lot going on to try and support the increase of bowel cancer screening, and that shows kind of in the step change we've seen from the February data to the March data, but that isn't us taking the foot off the pedal. The blood pressure question, I don't know the exact details, but we are just setting out under our population health management program around the hypertension and putting blood pressure machine tests in places like libraries and that kind of thing. But I can find out, unless you know, Keith, we can find out that information for you and pass it back through Nikki for your information to let you know exactly what's happening with that.
And it will be a good communication strategy for you as well, in regards to letting residents know that this service is available and
yes.
Have to wait to go to GP to
yes.
get blood pressure monitor.
Yeah.
If I can just pick up, just in terms of the hypertension piece, it is when I spoke about the model that we've done of care and wanting to get more upstream and do more anticipatory, hypertension is our number one priority because it comes out of our joint strategic needs assessment. It's the biggest cause of ill health in Hillingdon, and we're doing two things to try and get upstream. We've got money from the ICB to fund this. One is what we call active case finding, so proactively finding and making contact with people through GP systems who may be at risk of hypertension and working with them. So that's the proactive part. And then the bit you've referred to in terms of the libraries, that's about people who are walking up the street have the ability to have their blood pressure taken. So we're trying to cover two angles, proactive case finding and that incidental cases where people will just walk in. We're trying to put them into places where people go, and we're using our community champions to do that. So that's our number one priority in this anticipatory care.
Thank you. Thank you, Patricia. So we're going to move on to our next person, and that's Derval Russell from Harefield Hospital. Hiya.
Hello there, thank you. I promise I'll do less than 6 minutes because Patricia has very helpfully explained some of the elective challenges that we're experiencing as well. So if I start just briefly covering the challenges over the last year and a bit about the performance, and then talk about sort of what's our priorities going forward. So elective recovery is basically where a lot of the effort is going at the moment. So after the pandemic, our waiting lists almost double in size for some of our sickest patients, particularly those awaiting cardiac surgery. So we have, over the last year, been trying to crack through that waiting list. What has hindered us a little bit is normally we have, and I'm talking particularly about the Harefield statistics at the moment because that's probably of the most interest to you. So we would normally see approximately 2/3 of our activity being elective and 1/3 being emergency and non-elective. And that might be emergency work either coming through the Heart Attack Centre, the North West London aortic dissection service, or it could be from another hospital. A patient's turned up in A&E and they get transferred to us. What we have seen since the pandemic is a flip in that activity. So we've seen a big increase in the emergency patients attending, which has then limited the amount of elective backlog we can clear because we still only have the same amount of theatres, same amount of cath labs. So that's been a particular challenge. We are beginning to see it sort of lower slightly, but it's still nowhere near pre-pandemic levels. So that's been a challenge. You could kind of say, well, why aren't you doing, weekend lists and everything like that? The difficulty is workforce, and that's one of the challenges I've mentioned, is about recruitment. So at various times throughout the last year, we've had major recruitment problems. So we had particularly qualified nursing issues, and like Patricia mentioned, we had a very successful overseas recruitment drive, and we are almost fully recruited for nursing staff, which is great. What we do have, though, as a result, is a lot of new staff that have joined the organisation that are still going through almost induction, shadowing, so it's going to be a while before they are at the level of competence and experience of some of the staff that have left. Why did staff leave? Some of it's the pandemic, some of it's Brexit. It was just kind of perfect storm. So in terms of elective recovery, we're continuing. So we've done well with the nursing staff. We've done well with cardiac physiologists, but there's a bit of work to do. Almost everything you do at Harefield and Brompton hospitals requires a cardiac physiologist, whether it's or a perfusionist if it's in a theatre. If you don't have them, you can't do the cases. They're a very small, very specialised group, and there's also a national shortage. So we've been doing a lot of work through our relationship with Brunel to develop potential apprenticeships for that group, and also MSc programs. So we're trying to address the here and now, but we're also trying to address the lack of supply for the next 3, 5, 10 years. The other group that's bothering us particularly is we normally have a steady supply of overseas doctors coming to us, particularly for critical care. We have a huge amount of critical care at Brompton and Harefield, and those doctors have stopped coming. And again, we're not quite sure why, but we're now at the stage of, in order to keep all our critical care beds open, to keep our flow of patients, we're looking at an overseas recruitment drive for those, so to get a bit of support to help us try and fill those vacant posts, because we need to man our rotas. So electives been a challenge, recruitment's been a challenge, and the other one, waiting lists, and you mentioned some of the targets, Patricia. So the 78-week waits we've managed to clear, which is good, and we're now working on the 52-week waiters. There are less of them, so actually we're confident we're going to meet that. I would like to mention something positive that's happened out of all those problems, though, is we are very aware that patients awaiting cardiac procedures are deteriorating on our waiting lists. And you don't know, unless you have regular contact with those patients, how much they're deteriorating and how quickly. So we actually did a big transformation project over the last year, and we developed a digital platform where patients could literally log in their symptoms, and we could then look at it and flag if anything had changed, get them reviewed by a clinician, get their priority on the waiting list changed so they could be brought in. We are aware that in terms of inclusion of all our patients, not all patients would be able to manage that medium, so we are also doing risk of harm phone calls with people that aren't on the platform to kind of go, how is it going, how are your symptoms, how is your breathlessness and everything like that. And that has worked really well, had excellent patient feedback, and has allowed us to manage sort of the risk of harm to patients that might be waiting longer than normal for their surgery, for example. So that is something good that has come out of COVID, sort of. So in terms of capital investment, again, Patricia mentioned capital investment. The capital available to hospitals now has been cut massively. That is a concern to us. We have issues, particularly at Harefield, with power supply that are limiting future developments, and we also have our acute coronary care unit, which is a porta cabin, which isn't nice and sparkly, unfortunately, and is coming to end of life. So that is a challenge for us and a concern going forwards. We're doing lots around transformation and innovation, because if you've only got the same resource but a lot more patients to get through, so we're doing an awful lot about our critical care pathways, trying to make sure we take any waste out of the system, improve the experience for the patient, and that will allow us to see more patients. I've mentioned the work with Brunel, which is great, that is continuing, and we're also sort of increasing the research contribution, particularly that's being made at Harefield. We have a lot of world-renowned clinicians that aren't necessarily given the time to dedicate to research, so we're trying to make sure that they have ring-fence time to do that, and where appropriate, taking on additional staff to backfill them, just so we can continue to do the research, particularly into things like transplant, that there's limited centres in the UK that do heart and lung transplant. So that's probably it in a nutshell, but happy to take questions.
Thank you very much. Your mention of porta cabins gave me flashbacks to school and lessons in porta cabins. Temporary buildings that always seem to exist for the whole time I was at school anyway. But that's by the by. One of the aspects you mentioned, which we've not touched upon, because there's so much you can touch upon, but we know is a big issue across the NHS, is recruitment. It's huge and makes such a big difference to the services that can be delivered. Just for my information, really, in terms of the overseas recruitment process, how does it work? And specifically, how do you get permission from the Home Office to allow people to come in? Where do you target? And obviously, when the people come over, are they tied to Harefield Hospital for a number of years, or how do we make sure that that investment actually comes through in the way that we wish?
so I can kind of answer different bits of that. So overseas recruitment has been going for quite a long while. There is a lot of ethical considerations around it, and you are not allowed to go and recruit staff in a country that has recruitment issues itself, or if you took a large number of those staff out, it would mean affecting their health service. There are cases where sometimes you put out a job on NHS Jobs, which is the main place you advertise for healthcare professionals, and overseas people might apply for those jobs, but off their own bat. They're not through a recruitment agency, and they can do that. And we do get some overseas staff that way. But we also work with recruitment agencies that basically will go out and set up the interviews in the appropriate countries that have permission from the Home Office, and they will help with the visas, the onboarding. They will start the package of, induction when they fly to the UK, help them organise flights, help them with their induction package. The hospital offer them free accommodation for when they come over, and they organise events, just to kind of encourage the settling in process. There is an expectation that these people will stay 2 years, but we have some people that haven't, and it would be wrong if someone doesn't settle, is unhappy, to keep them here, because if you have unhappy staff, that's going to lead to it's going to be counterproductive. But most of them do stay, and actually if you think back to the previous recruitment drives, and Patricia, you might need to help me here, when particularly the Philippines, it was about 12 years ago, wasn't it, if not more, a lot of those staff are still working here and at Harefield. We don't have a problem keeping staff, we have a problem attracting staff because of our location, because we are kind of out there in the countryside. But once people come and they see the training and the development and the career opportunities, they tend to stay. So our problem isn't so much retention, it's recruitment. But we do use these specialist companies to help us with it.
Thank you. That was just interesting information for me. Rita.
Thank you, Chair. Just going on from your recruitment, how's the apprenticeship working with Brunel then?
So we are at the very early stages of it, but we're hoping that the course will start perhaps September of this year, but more likely to be the following spring. So they are working with us on seconding some of our staff to help set up the course. So it's kind of counterproductive. We're losing some of our staff to set up the course, but we're trying to over-recruit as a result, because we know this is the way to go in the long term. So those people will join a programme. They might be in health already, they might not be in health, and they will do placements along the way. And they will do a lot of them at Brompton and Harefield, but the other members of BPACs, Hillingdon, for example, has expressed an interest in maybe having echo students, because that's a bottleneck for them. And what will happen is those people are likely to end up then working in the places where they had their placements. So it will bring more workforce into North West London. There are a few other universities that do apprenticeships for cardiac physiology, but there is only Middlesex University that does it in London, so we need at least another provider, which is why Brunel are so keen.
Sorry, just to follow on there. So is it an attractive package that obviously recruitment's an issue, so how can we encourage, more apprenticeships to come forward? What are we doing?
I think there's a lot of, I think when apprenticeships first came out, there was the whole, how do you use sort of the money that's given to set up the apprenticeships. I think universities now are realising that this is a much more popular way of maybe recruiting into some of the gaps in the NHS. So they're working with organisations like the BPACs and everything with us in developing these apprenticeships. So I think there's been a shift change in the universities thinking away from, undergraduate courses, postgraduate courses, to actually what is needed and what will attract people. So I think it is more attractive as a result, because they quite often have jobs as they go along during it, they have salaries, as opposed to going and working as a full-time student.
Philip. Thank you. 3, one at a time?
You can decide whether they deserve to be packaged together or they're better.
Okay, well I'll
but I'm going to cap you completely at 3.
That's fine. Well, that's absolutely perfect. Okay, thank you very much for that. Really encouraging to see the progress being made against targets and against a very challenging backdrop. That's good to see. Well done on the Brunel work. Certainly in Hillingdon, we've got a long history of working with Brunel in terms of developing social care workforce, and that's been very fruitful, so good luck with that. Two things really, two rather than three. Firstly on transformation, you touched on some of the transformation work. I wonder if you could say perhaps a little bit more about that. And then the old chestnut of Harefield itself, the future of the site. I mean, you've mentioned it being out in the sticks. You've mentioned power supply problems, which I've never heard about until this evening. It's an anxiety that never quite goes away. I wonder if you can say anything about the Trust's long-term commitment to Harefield for that site. Thank you.
Can I start with that one while it's fresh in my memory? You might need to jog my memory for the other one. So in terms of Harefield, I think, as you know, Nick Hunter previously came and presented at these meetings, and he briefed you previously on the fact that we've merged with Guy's and St Thomas's now. We're part of, and this is why sort of there's two headers on the report, so we're part of the Heart, Lung and Critical Care Group. There is definitely a desire to develop Harefield, and what we are collectively doing is we're trying to develop a master plan for the site, because obviously if you want to expand the site you need to know long term what you're doing planning permission wise, but we are addressing the electricity supply. So the issue is actually the supply to Harefield Village as a whole as opposed to the hospital. So Southern Electric are working with us on a 5-year plan to start to address that. So we are limited, but it's probably going to take that long to get the master plan and everything in place. So there is definitely encouraging mood music to developing the site and potentially even increasing rehab facilities, further developing the transplant service. So it is optimistic future. That was the second one.
Good to hear. I shall remind you of the first. It was just about the transformation work.
So it's all around the fact that you have set facilities, set staff or restricted staff. So if we take, for example, our issue is we need to get more cardiac surgery patients through. We have a limited number of intensive care beds, and we're looking at, for example, you have different levels of care. So you might have a ventilated patient in level 3, a more HDU type patient in level 2, and then going to a ward. You can address a bottleneck at one of those places, but if you don't address the whole lot together, you'll just move the problem to another place. So, for example, we're looking at our day of surgery admissions for cardiac surgery and thoracic surgery. So instead of a patient coming in the night before, they will come the morning of their procedure. Again, we asked patients, was this what they wanted? Because it's very important we don't just inflict things on patients. And we actually did a survey of patients, and they were keen. They said, if I'm going to have major cardiac surgery, actually I'd rather be with my family the night before and then just travel in the morning to the hospital. So that has created a better flow through the sort of ward beds, but at the same end we're doing work in the critical care. So I suppose the transformational bit of it is trying to do it across the whole pathway instead of just addressing little bits piecemeal like we have in the past.
Thank you.
June.
Just quickly, you talk about the, your porta cabin and the impact and lack of power supply. Can you go in depth a bit into that, and how do you manage that and the impact it causes on the service you deliver?
Yeah. So kind of the electricity supply, I feel like I've answered, but if you've got further points of clarification, absolutely happy to answer them if I can, and if I can't, I'm happy to get the information and come back to you as well. So the porta cabin, we have regular condition surveys of our buildings as part of our backlog maintenance programme, which is basically, and I think you referred to this as well, Patricia, it's the list of everything that needs addressing in the hospital, and you're continually prioritising it, so you know that next year's capital we need to do those 6 things urgently. So those condition surveys help inform the prioritisation of the spend. So for example, Oak and Acorn Ward, which is our acute coronary care unit, sometimes you'll see it referred to as ACCU, 5 years ago it was identified that the wooden floor in the porta cabin was beginning to fail. So actually we managed, and it was hard work, but we managed to shut those wards for a period of 6 weeks and replace the floor. So we knew that gave us another 5-6 years. So that is how it's being managed in terms of keeping a very close condition survey of what's happening in the buildings, but whilst also building up the plan for how are we going to afford to replace this, when are we going to replace it, and what are we going to replace it with. So lots of discussions, but yeah, you're absolutely right. There is at least a condition survey done on it every 12 months to just see what's happening.
Thanks. Thank you, Devil. Right, let's move on. Dr. Paul Hopper, it is yours from CNWL. It's your turn.
Thank you, Chair. Yes, good evening, everybody. I'm Paul Hopper. I'm one of the medical directors in CNWL. What we've set out in our paper is a summary of the service developments that we've made over the past year, and what I'm going to focus on are the adult services developments and also the children's services developments. So I'll start with the children's service developments of note. And something that we're particularly pleased about is the development of our more comprehensive early intervention services for children and adolescent mental health services. And so what we've set out in our paper is a description of the components, the building blocks of what makes up a comprehensive offer. For example, in the inner boroughs in London, other boroughs that we serve, there has been for some years a successful under 5 service, which is tried and tested, really useful in terms of helping families where the under 5 is struggling with, let's say, sleep problems or anxiety or tantrums, etc. And it's a service that can focus with that family on how to make interventions in a place that is suitable to meet. And that's something that we're recruiting so that we can open. We've made good progress, not quite there yet in terms of opening that here in Hillingdon, but we're getting there. Similarly, mental health in school services, also tried and tested elsewhere, and we are similarly recruiting, and shortly we'll be able to roll that out in Hillingdon. We've made reference to the R's services, and that's a link with the sorts of things that we heard from Keith earlier. These are link workers, in effect, who are placed in PCNs, and in fact Hillingdon is going to be at the forefront of this, really, in terms of our London footprint, because here in Hillingdon there will be one of these R's workers for each of the PCNs in Hillingdon, and that isn't the case, for example, in other boroughs, and they will be a link between primary care and the specialist CAMS services. So these are just some examples of the elements that make up for a more comprehensive offer. In terms of core CAMS, which I know we've come to talk to you about performance in core CAMS relatively recently and will be coming back in the months to come. So I'm not going to say terribly much about core CAMS, except to say that looking at the last 12 months, there's been really quite impressive performance. When I say quite impressive performance, in terms of Hillingdon performance, over the last 12 months, consistently, we've met the 18-week target and achieved that in at least 95% of the time. More recent months, we're always managing to meet, to see people within 18 weeks. And in terms of looking at it from the other direction, how many young people are waiting to see us, that's also come down very significantly over the last year. And when I say waiting, both in terms of waiting to be assessed, but also if young people are waiting, having been assessed, or now waiting for treatment, we've reduced the actual numbers of people waiting by more than 60% in both cases. So moving on then to our physical health children's services, we have a range of what you could call, in summary, 0 to 19 services. So these would be therapy services, for example, speech and language, or physiotherapy, occupational therapy. Those are back up and running in terms of seeing people face to face. Similarly, our health visitors and our school nursing services are all up and running as they were before the COVID period and meeting their performance targets. In terms of our adult mental health services, our focus, particularly since last autumn, has been on what we call flow. In other words, helping to manage the acute demand. And we've been doing a number of things under what you might call winter pressures initiatives. So, for example, one of the things we did in the late autumn was to open what we call an MCAS. It's a clinical assessment unit. It happens geographically to be based in one of the inner boroughs, but actually its function is to take in people who have come to A&E departments across northwest London within our areas of responsibility, to take them in for a period of assessment so that the individual is not left to wait in an A&E department where it is possible for them to continue an assessment at a more appropriate venue. That's what the MCAS is there to do, and that's proved to be successful and helpful in terms of bringing people out of A&E departments. We've also opened in the late autumn a specialist rehabilitation triage unit, and that is helping our acute mental health wards with patients who may have been there for some time, maybe more than 30 days or even 60 days, and it's not entirely clear what they need in order to successfully return home. And so what this particular unit does is brings people from our acute wards for a period of more intensive rehabilitation assessment, and then it becomes clearer whether they need formal specialist rehabilitation or can be supported to move home. We've also, since last summer, had the crisis house, and that has been very helpful in terms of being an alternative to a hospital type setting. So somebody, an adult with a mental health crisis, is able to go to the retreat, spend some days. It aims to be for certainly less than a week, and then with support, with advice that's available on site, they are able to then settle, and as our paper demonstrates, in the vast majority of cases, people who access the retreat are then able to return to their own homes, not having had to be admitted to a hospital setting. In addition, something that's not new but that's certainly continued to prove its benefit has been the coves, which is something that people can access for on-the-day crisis support, and that's open for extended hours on a daily 7-day basis, and that worked well last year, and we've continued to support that this year. In terms of our community physical health offer, we've presented our performance in terms of rapid response, or urgent community response as it's now called. That's performed very well indeed in terms of meeting their target of seeing people within 2 hours, and that's of course in the face of a rising demand. So being able to improve the ability to see people quickly is quite impressive. And as a final point I'd make before ending this, something that was again set up as a winter pressure initiative a few months ago was the Discharge Liaison Project, where some of our community nurses, 2 of them, were placed within THH and working with the acute wards, and the purpose was specifically to help to identify individuals who could move out with that little bit of extra expertise and support to move out to a community setting. And what I would say about that was it was a very impressive joint venture. Like many things that we do when there's a winter pressure, one sets it up, it works well, and then one realizes perhaps a little too late, if only we had done a proper evaluation. So I remain hopeful that that's something that we'll see the value of in the year ahead and evaluate its benefit. I'll stop there and happy to take questions.
Thank you. Again, so much that we could possibly ask about, because there's so much different work that CNWL does across the whole of Hillingdon. I would like to ask a question though about the 2 alternative sort of places of support, the Crisis House and the Cove Cafe. My first question is in a couple of parts. The first part is it being used as well as it could be? Is the capacity being used? And then the second part of that is it a success? Is it doing a good job? And the third part of that is it something that we should think about scaling, or is it something that actually is meeting a specific need and that need is within the capacity? So basically those three parts on the Crisis House and the Cove Cafe.
I'll deal with them separately. In terms of the retreat, this is the unit where people would go in for 5, maybe 6 or 7 days before ideally returning home. To answer your question, how well used is it? On the one hand, it's relatively new, but it nevertheless has to be said it is not as well used as it should be. And in that context, we've had meetings, and this involves our ICS colleagues as well as our local authority colleagues and ourselves, have met the provider of the retreat to talk about how can we improve use of. And there's some very practical things that we've done about that. So, for example, we had, I suppose you could say, a fairly restrictive access arrangement of vetting, and then only a particular group of, or should I say, a particular cohort who are involved with a particular service could have had access. So we've now widened that so that the potential cohorts who could access this are wider. Naturally, what that means is that the retreaters needed to have further assurance that the safeguards are in place, so that what was initially quite a straightforward, if this team would refer to the retreat and the backup would be there. If you now widen access, it means that you need to be even more sure that the backup is there if people need additional support at various hours. So we've now have that agreement, and we're putting that in place that a wider cohort of people can access it. In terms of success, I think for the retreat, the numbers that have gone through, I honestly think that seeing how many people have managed to return home versus having to be admitted or some other form of crisis arrangement is very impressive. So in that sense, it's certainly met the objective. In terms of scale, there are other crisis houses like the retreat in other boroughs of northwest London, and what we've found, it's relatively early, but where they have relaxed access arrangements and built-in safeguards around that, they've actually proven to be highly valued and beneficial. So I think that in terms of scale, we need to move ahead with the widening access arrangement and then judge, are we getting good use and still managing to get as many people home as we have before. In terms of the Crisis Cafe, very good numbers going through. One of the considerations, though, is it in the right place? And so we've made reference in our paper to potentially relocating it and having a stronger arrangement with the retreat itself, because there should be a natural synergy there in theory, so we should explore that.
Thank you. I mean, they're both really interesting ideas that I'm really keen that we're happy that we're trying, but yeah, no, it'd be interesting to see how they develop as they go along. So, Tony.
Yeah, thank you. Just on the retreats, I think it's interesting the numbers, but I think when we had the presentation before, I did raise the point about the outcomes, and I'm pleased that we got an email the other day with 3 scenarios from clients, called them clients, that have used the retreats. I found that rather interesting, and I'd be interested to see more in the future, because I think it might be great if you're seeing hundreds of people, but if the outcome is that they're just slipping back into the system, it's not satisfactory. But seeing that most of them are returning home and we're avoiding using further mental health issues, I think it's good. So yeah, I think it's a pat on the back for it, and as I say, it's early days and it needs developing, but yeah, I'm in favour of it. Yeah, thank you.
Councillor, if I could just respond, you make a very good point indeed, and the point I think is also about how somewhere like the retreat is unlikely to be successful in isolation. And one of the things that I think came through those scenarios that were sent on to you was that people who are going to the retreat often have what we might call some enduring difficulties around mental illness or personality, and so having support in a crisis is of course very important, but what is there going to be that will support them to make the necessary changes in the longer term, that they don't need to keep returning to the crisis? And so that's why we're also doing work on complex emotional needs team, which means this is a very specialist sort of service that helps people, for example, with personality difficulties, to make those longer term changes so they can cope more effectively.
Yes, we definitely want to find out more about that. Philip.
Thank you. I'll resist asking a question about CAMS because we do that elsewhere, no doubt, although we'll certainly take account of what you said this evening, so that's useful. My question is really around addictions, and certainly from memory, Hillingdon was a bit of an outlier in terms of drug and alcohol related admission to hospital. I think I'm right in saying that. I just wondered what the position was now and how things are working in relation to Arch in that regard. Thank you.
Councillor, I have to say I'm afraid I can't say very much about addiction services, not being part of our particular clinical division. So that question I'm very happy to get a response to outside of this meeting.
Okay. Can I just say, it appears among the services in the report listed under CNWL, but if I've got that wrong, that's fine. We'll find out from elsewhere.
It absolutely is, just not the division of CNWL that I'm familiar with.
No, you're a big organisation. Fair enough.
We look forward to getting that response. Thanks, Paul. June.
Just quickly, because the retreat seems not to be used as it is supposed to be used, and even though we don't want to talk about CAMS, but it will have to be a part and play in it, because we had a couple of reports about access from Hillingdon Hospital for people who come in with mental health. Can this not be used to redirect those individuals who going into crisis or some form of crisis stage, and use the retreat to enable to get a balance with that? You know, how are you working together with Hillingdon in regards to using the retreat to alleviate people who turns up there and the facilities is not available for them because they don't have that facilities there for them?
Councillor, could you say a little more about the facilities that are lacking? What's the gap that you'd like me to comment on?
Well, there's a gap that we were informed at our last previous two meetings we had about CNWL and adolescents having there's no access or facilities available when they turn up at Hillingdon Hospital A&E in crisis. And sometimes the crisis that they turn up is because the hospital don't have the provision for that. They have to employ staff, specific special staff, like RNs, mental health nurses, to deal with that. But the retreat, if the people are there and it's not being used, is not a way that you can work with Hillingdon Hospital to enable that service to be available, so that those individuals, if they do turn up, there is somewhere that they can go to directly, and then don't have to have that impact of the hospital surrounding around them. And that's people in crisis, which we hear a lot about, but used for another area.
Thank you for clarifying. And I completely follow the logic of what you're saying, and that would, I suppose, be in keeping with the 16 to 25 developments that we've also described in our paper, trying to smooth that transition between child and adolescent services and adult mental health services. However, in terms of a residential or a ward placement, it wouldn't be possible to mix, for example, 16 or 17-year-olds with adults. So the retreat is an adult only, an 18-plus facility. But I think you also are making a very important point about what is there available for, let's say, an adolescent of 16 who is in crisis. And you're right to say that it can be difficult to find the right disposal. So, for example, if a a person in that position, a young person in that position, clearly needs inpatient specialist CAMS treatment, then that will be found. However, many young people who attend A&E in crisis, it's not that clear cut. So they often are not in a position where they clearly need specifically acute mental health input. But what they need is a mixture of perhaps mental health support, but an appropriate place to be, an appropriate place to live in the community. So it's often a conjoint effort between health, local authority, etc., to find a solution for them. That can be complicated, and there are particular rules around a young person being accommodated in a place that hasn't got the right accreditation. So that makes it more difficult. I would just say as a final point around that, yes, it is tricky, but something else we've described in our paper is the urgent care outreach service. So this is something new, where if our urgent care services see a young person in crisis in A&E, it's decided that they don't need to be in hospital, but they do need some intensive support in the community. That's what the outreach service is now able to do. So that's an additional form of intensive support.
Okay, thanks, Paul. Thank you for that. Right, let's move on to Clinton and Chris. Let's talk about the London Ambulance Service.
Thank you, Chair, and good evening, everyone. In the update that I submitted, I talked quite a lot about the trust work that's been going on the last year. It's probably more appropriate today that I talk about local initiatives, as we are one of the only trusts that cover the entire London. One piece of work that we're currently working on, and the reason I start with this is it will answer a lot of questions in terms of where we are with our targets, is the introduction of teams-based working at the Hillingdon Group. And this is a complete overhaul on how we work within our group. Historically, crews go out on a variety of separate individual rotas to respond to the public, and what we're doing is bringing them all into separate teams with a specific manager. And as a result of this, we've had to look at our demand modelling to make sure that we're using the ambulances at the right time for when we have those peaks in demands with the resources that we've got. So hopefully with a review of this that hasn't been done in probably about 6 years now, I'm looking at Clinton, it's quite a while to really make sure we're using our resources, have the rotas to respond to London with the best possible way. And so we are looking forward to that. Our implementation date for that is aimed at September. If we can get it in sooner, we will, but mindful of all the sort of complications that it brings. But what this does do is increase the support that we are giving to our clinicians. And I think it's important to bear in mind that some of our ambulance crews go out as a pair, quite possibly straight out of university, having to deal with some horrific scenes, and when they haven't got a manager on the same rota as them, it might be a delay in getting to them and getting that welfare and support and clinical support as well for them. So we're really excited about this piece of work. We think it's going to increase the culture, the positive culture of the Hillingdon Group, help respond to the public in a quicker time. And the reason I talk about this is because obviously Category 1 and Category 2 response times will always be a focus. How quickly are we getting to our Londoners? And it is a challenge. I'm pleased to say that recently we are certainly responding to our Category 1 times in an acceptable time frame. It's not always the case. That wasn't the case over winter, and it certainly wasn't with our slightly lower acuity calls as well. But with an extra FRU that we've put on, we have seen those times, because I remember last time we met we talked about that and hoped to see that those times improved. They have, which is fantastic. I think there is no coincidence that it wasn't in winter, so I can't take all the claim for it. I think it is part of the time of year as well, but I'm pleased to be able to say that has improved. We look at quality as well at the Hillingdon Group, and very pleased that we're going to contribute to improve our alternative care pathways. Clinton might be able to sort of add on one piece of work that's been going on with the Hillingdon Trust with the frailty unit, but it's another weapon in our arsenal to making sure that we're avoiding unnecessary ED conveyances. We are aiming for below 50%, so at present we're taking about 51% of the calls that we go to, or 51% of the calls that we received to the ED. So we're aiming for less than half conveyancing to the ED. We're doing this by increasing our clinical development with our staff, making sure that they're getting the support that they need and the confidence to be able to discharge at scene. And it's got to be put in the context. They don't have the diagnostics that other services may have. They've got to make pretty important decisions on their own out in the field. So really keen to sort of improve their development with that, and teams-based working will help with that. We're introducing more training days throughout the year, more stand-down time to make sure that we're giving them the appropriate feedback when things don't quite go right. And again, it's one of those situations, they never get feedback. We never truly know if we got our differential diagnosis right when we take them to hospital. And so it's a very difficult job for them to go out and give it the best care with the limited diagnostics and then never know if they got it right. So it's a difficult balance for them. So we're really keen to improve the support we give our staff. With them feeling confident, they'll be able to increase those important referrals to help take the pressure off other services. I'll leave it there for any questions. Conscious of time, I could go on for all night, really.
Thank you for not going on all night. But no, that's good. And obviously, the two bits from the report really happy to highlight is that obviously the fastest average on-scene time for critical patients in our area, which is really positive, and also the partnership working done with Hillingdon Hospital to reduce hospital days, something that's been in the news. You've seen pictures of, obviously, but the average time of 22.5 minutes, which seems not too long compared to national averages, has actually even gone down to 17.8. So those are two really positive things from the report, which come out. My one question, sort of based around that, is: do you feel that you have in place the systems to try and move patients to the right place as quickly as possible, and are not, I don't want to say wasting time, because you've got to be with people until they can go to the right place, but do you feel like you're there yet, or do you feel like there are certain issues, maybe, for example, police coming when there are people in distress or all that sort of stuff?
In short, yes. And I think technology plays a massive part to that. So we've taken the digital journey last year on our electronic patient care records. And that's really enabled us to access across the piece. So when we're talking about the codes, for example, we've got ready access to that information on a tablet. So crews are not having to remember pathways and remember exclusion or inclusion criteria. And it's really about the fact that our crews are able to then have that clinician-to-clinician conversation across the piece now. With some confidence as well, and I think that's the key phrase that we were talking about. It's about supporting our staff, because they are out there as band 5, band 6 clinicians making very autonomous decisions without that top level support that you would normally see in other services. So yes is a short answer, that we really have, and certainly we talk about things like summary care records and universal care plans, and that's becoming really, really useful for us, because we can actually access them on scene. So when it's 2 a.m. And we can't necessarily speak to the GP direct, actually we can see what care plan is in place for that patient and make the right decision, because it may well be that ED at 2 a.m. isn't the most appropriate for that patient, but actually the crews are then supported by that information that they can view on scene to make potentially a delayed response that might be to an urgent care team or a district nurse later in the morning. And that's really powerful for us, because so we don't have those conveyances to ED that are completely unnecessary and sometimes detrimental to the patient.
That's really positive, actually, the idea that your crews have access to the right information as quickly as possible in order to make the best decisions, and that includes knowing about things like the Cove Crisis Cafe, if that is appropriate, for example, rather than just overloading emergency departments with everything, because you're right, I mean, in other areas we've looked at, part of the problem can seem to be the one obvious place to go is the place that people go, because they don't know about other pathways, which overloads the one obvious place. So, no, that's a really interesting and positive thing. Excellent, thank you. Does anybody else have any questions? I'm going to go for Barry first, June, because you went first last time.
Yes, I've seen you secured the money for the new greener vehicles. And so how many electric vehicles have you got at the moment? How many will you be getting soon? Any time frame on that, or any update on?
Yes, so this trust-wide initiative is to bring in to fast response vehicles, so the cars, not so much the DCAs, but electric vehicles is part of it. I can't give you figures on how many we've got. I know they are in. I'm hoping you.
So we've got a massive fleet. I know there was some press earlier in the week about how much we spent. So we've got 42 electric fast response cars that we've bought. But we've also got a massive fleet of hybrid ambulances that are coming along, and we do have a test fully electric ambulance, and also a lot of our support services, so our IT and our vehicle prep services. So a lot of that support services we're moving to an electric fleet. So we're following the government mandate, but obviously we need to be very mindful that we are a 24-hour service, and some of the certainly the emergency fleet, so the emergency ambulances and some of the cars are pretty much 24-hour services, and so they're not necessarily suitable for electric vehicles because we don't have the opportunity to charge them. But that's a journey we're taking. Currently, we do have the largest electric fleet in the UK ambulance services now.
If I may, I think it's quite important also to talk about what's been going on for decades now in the cycle response unit down at Heathrow. They often get forgotten about because they've been going for so long, but a really successful initiative that went on that's continued to make sure that we're getting to the patients of Heathrow Airport and the surrounding areas. It's a lot quicker on bike, surprisingly, than it is in any other vehicle.
Sorry, Barry, you got another?
Sorry, yes, I worked at Heathrow Airport and met them. I was a fire marshal there at Heathrow Airport, so and Terminal 5, and we closed different sections down at the time with the fire, so you carry on. Okay, very good.
Jean.
My issue is with the staff sickness rate. How is the staff now? How are they now coping with all that drama throughout COVID and everything? What is your sickness rate? I know you got something in here, but is the level coming up now and staff getting, settling in more in being able to deliver the service that they're required to do?
Yeah, thank you. It has been an issue over the past few years, the way they've responded to COVID. We had huge absenteeism back there, but I am pleased to say that actually over the last year, our specifically long-term sickness is very clearly going down month on month. It's a wonderful graph to be able to sort of represent as, and we've done this, and I think this is actually testament to the wider NHS, because these people need the services of the NHS for long-term health problems, and they're now kicking in. And so it's actually be able to help for the staff that have got those long-term problems. Short-term sickness spikes. I mean, a few weeks ago we saw a number of people who had tested positive for COVID again within our staff base. You know, we're trying to promote appropriate PPE when they go to the calls. Highlighting Strep A was another recent concern that of people going to it, and so if we do see any spikes within it, we take appropriate action to make sure that they have got the appropriate PPE, they're wearing the appropriate PPE at the time, and getting the appropriate support from all the welfare referrals that the trust offers, and it is a comforting amount that we can offer actually to our staff to give them the best chance of recovery and coming back. But to be specific to your question, yeah, things are beginning to settle, thankfully. I hope it stays like that.
Thanks. Philip.
Thank you. I mean, some really exciting developments, and it's great that we're harnessing the power of digitisation to the full. So that's great. As a London-wide trust, I imagine, it's 5 ICPs you deal with, is it? 5? So I imagine there are opportunities to identify good practice and share it. Can you say anything about that, and what's the quality of your interface with the ICP in North West London? How does that work? Is that a strong relationship?
Yeah. So yes, very much so. It is a almost daily relationship. We work absolutely hand in hand to make sure that we are putting the benefits across the whole of the ICS. The answer is yes. It's a short answer in everything we do. So there is ED and emergency services and urgent care links, but there's also primary care and more of the secondary care as well going on. So there is not just one person speaking within the ICS. There is literally an absolute cross-pollination going on a daily, if not a weekly basis. And then the ICSs themselves, there is work that goes on at the Pan-London level as well, to make sure that, just for example, in terms of to bring it back to Hillingdon and the Northwest, in terms of services, if I develop a service in Hillingdon or develop it in another borough, we absolutely look to develop that within the boroughs as well. So there's a real cross-pollination to say, actually, if we've got a service that's available here, can we make that available to all of our different boroughs and different teams?
Thank you very much. And I shouldn't mix up my ICS and ICP. I'm mixing those up, but apologies. Thank you for that.
At this time in the night, Philip, no one's counting. Brilliant, thank you. Lisa, what are Hillingdon Health Watch interested in at the moment?
Thank you. I shall run through Health Watch Hillingdon in about 60 seconds. So for anyone who doesn't know who we are a local... Oh, what here? There we go. Does that work? It's on. There we go. There we go. Right. So we are a local charity that is commissioned by the local authority, and we're here basically to make sure that people are at the heart of health and social care. So our purpose really is to understand the needs and experiences and concerns of people who use health and social care services and to speak out on their behalf. We do that by gathering views and understanding experiences, making people's views known, and we do that by sort of writing reports, making recommendations. We sit on a lot of the sort of strategic meetings in the borough, and in fact, I would say in terms of sort of health watches across North West London, I think we probably sit on the most meetings, which is good, and I always assure our residents that we are definitely in there and part of the conversation. We promote and support the involvement of people in decision making and in scrutinising services and holding services to account, and we can also make recommendations for investigations of Care Quality Commission as well. So we also have some statutory powers of enter and view, which we haven't exercised for some time due to COVID, but that is always there for us to use if we need to. And any sort of views and experiences that we come across, we report up to Health Watch England and the NHS. So how do we work? So we have an information and signposting service, so residents can contact us if they need to know sort of what services are available for them. If they want to make a complaint, then we will signpost them and advise them how they might go about that. Essentially our core function is community engagement. So we run outreach programs, and we are volunteer-led. So we have a board of trustees and a team of volunteers that we work with that help us to do our work because we're quite small in number. And yes, we make reports and recommendations. We also have Young Health Watch Hillingdon, who I'm very proud of. So they're a group of young people who work with us to direct the work that we do around children and young people services and make sure that children and young people's voices are part of the conversation too, because they're just as important. So some of our achievements over the last 2 years. So we did some work around GP online consultation, where we sought people's views about using online services, and through that we were then part of the evaluation process for the patches system. So we're still very much involved in the rollout of that system and monitoring feedback from residents that are using it, and making sure that that's fed back to the appropriate forums. Our Young Health Watch team did a review of sexual health services in the borough, which has sparked a review of sexual health services in North West London across lots of different boroughs, so that's really good to know that we've had some influence there. We've been very much involved in population health management work, supporting engagement with residents around sort of falls and frailty, and that has influenced sort of thinking in terms of future pathways and interventions, and also we're sort of continuing to do some work around end-of-life care as well, where we've gone out and sought people's experiences. We were commissioned to do a review of the London Ambulance Service to influence their 5-year operational strategy, and you'll be pleased to know that I think we had over 450 responses, and everyone was sort of very positive about the service, so good news there. But we've made some recommendations, and we're just waiting to find out whether we can publish the report. We've been supporting work to tackle winter pressures and inequalities, where I've been facilitating a programme of work which is around connecting communities with local pharmacy services, and connecting, so we're developing health and wellness sessions that will be based in the warm welcome centres across the borough. So again, raising the profile of pharmacy, but also raising the profile of community assets. And we've also done a review of GP websites regarding patient information on how to complain. Moving forward, children and young people's mental health services is always a priority for us, but we have, I'm working with the Joint Commissioner for Children and Young People's Services to reinstate Thrive meetings in the borough. So we've had 2 of those so far. We've done some mapping around mental and emotional support services and how everyone can work more closely together to make sure that there are clearer pathways to support. Again, supporting population health management work around detection of hypertension in the borough, and also tackling obesity. Planning for winter, and again, through the sort of pharmacy-led health and wellness sessions, we're looking to put together a more seasonal programme of events that will help prepare the community for winter, and impart some sort of important health messaging. Dentistry, that's always going to be, that's a big issue for us at the moment, and we're working closely with Health Watch England to support them in terms of sort of how future commissioning is influenced. I'm sure we're going to be involved in Hillingdon Hospital redevelopment, and we've been supporting sort of the hospital with place assessments, and also primary care. Recently, our Young Health Watch team worked with the Confederation to pick the winners for the primary care awards, which was great. And we're working on growing our digital community, which has sort of been expedited, if you like, through COVID. We've been producing podcasts where our volunteers will interview professionals and have discussions about services, and just helping sort of signpost people to services. And I will leave it there, I think, and just open the floor for any questions. Thank you.
Yes, no, well, thank you for the work you do, and it's great to see that a lot of your work sort of mirrors the type of stuff we're doing, we're interested in, which I hope means that we're sort of in synergy rather than we're missing something very, very obvious. I know I do, and I know the rest of the committee find it really useful to get the information that you receive. I know attending a lot of meetings can be painful from personal experience as well, but it's good actually that the knowledge that you collect is plugged into a lot of our services. That is very good. So I don't have any particular questions apart from do read all the reports. But Philip, you have a question.
That'll be fine for me. It's extremely valuable to get your input on these meetings. I think in the nicest possible way to our health partners, part of our scrutiny role does require us to, if you like, validate and get an independent take on some of the things we're having presented. So that's valuable. Quick question: how are you with volunteers these days? I know a lot of your work depends on a volunteer base, and I know that can ebb and flow a bit. How are you at the moment in that regard?
So we certainly experienced a decline in volunteering, and I think that that's a situation that's across the board, really. I think cost of living crisis has had an impact on that. So a number of our volunteers went back to work, sadly. Well, good for them, but sad for us. After COVID, and yeah, so that has been a bit of an issue for us. We're starting to see more interest from students, which is quite unusual, but certainly medical students that are looking for experience. So that's really, really good. But we do need board members, so and we do need more volunteers to be able to, continue to do the work that we do. So yes, it's something that, I know we're not alone with these issues, but hopefully, we'll start to see some more people coming forward. Yeah, thank you.
I think that's it. Yes, fantastic. Well, thank you, Derval, Clinton, Chris, Lisa, Patricia, Keith, Sue, and Paul for coming along. I know it's a long meeting, but we find it really, really useful to have you all together to talk about what's going on in Hillingdon. So, you're now free to leave before we continue the rest of it. Thank you very much. Get back to our meeting. There's two more items. I don't think they'll be very long, but that's not completely within my power. But anyway, we shall see. Okay, the Cabinet Forward Plan. Is there anything on the Cabinet Forward Plan that we would like to look at that we don't already have a look at? Are we good for now? Yeah, because the older people's plan update we're going to be getting, aren't we, for example? I have actually, I witnessed this under the next item. We'll discuss that. Okay, should we move on to the next item then? Yep. Agreed, fantastic. Okay, the work programme. So, where are we? Let's just look for the next couple. June and July. We get a month off in May, which I think we deserve. So, in June we've got the, is it the older people's plan? I need to get a ruler.
I've folded mine.
That is an excellent idea. So that's the older people's plan. We're going to obviously have an evidence session as well. One of the things that I have asked for that has come up recently is our move as a council towards family hubs, or family hub delivery, because some of the services that are going to be delivered from family hubs come under our remit as being health and social care. So I want an update on, on that, and I was thinking probably the June meeting, while the consultation is still live, so we can hear about how hopefully those services will be delivered better. Of course, we're going to have our final public evidence session in June before we put together a draft report for July, I think, on the canvassing. So yeah.
Chairman, I think in terms of the review, so we'll have the final witness session in June, and then at the July meeting, I can start before the meeting, I can actually start drafting some recommendations based on the feedback from members, that we can then actually run through at that meeting to then do the final report over the summer.
Okay, and that would actually be quite good, because summer's a good time to do that. So yeah. Does anybody have any views on the work plan? I think it looks pretty good, and there's still quite a lot of stuff on that keeps...
Plenty to do.
Yeah, plenty to do. Well, yeah, definitely. We have long meetings, but I don't think you can justifiably make them shorter without not doing our job properly, can we? Yeah, go for it.
I just think we do have to do justice. I mean, particularly this evening. I know it was a long meeting, but it could not be, quite frankly, so... I do feel for you, Nicky. I'm looking at you.
What can I say? It's a cross I have to bear.
Well, yes, and we're thankful, because if you didn't bear that cross, I'm sure somebody else brilliant would replace you, but we're very thankful. But yeah, no, it's true. Long meeting always, but yeah, no, this is such an important area. Okay, so shall I propose the meeting closes? Fantastic. 9:15. I was aiming for 8:30, so not too bad. Anyway, okay. Thanks everyone.